Can we ask Stuart to start streaming, please? And of course, this will be going out on YouTube, members, just so that you know. Are we okay?
Yeah, thumbs up.
Thank you. Thank you very much. So good morning, everybody. Welcome to the Health Scrutiny meeting today, September the 7th. And welcome to Inis Griffiths, who is the Chief Commissioning Officer at Bassett Law. And we don't seem to have a Health Watch representative this morning, but may come later, perhaps. Now, members will be aware from the discussion of this topic at the July meeting and the briefing papers in the pack that this item that we have on the Bassett Law Hospital is to relocate the inpatient mental health wards from the Bassett Law Hospital to the new facility at the Sherwood Oaks in Mansfield.
Interrupting, so we should probably formally start the meeting. With
we better. All right, we'll go back to that. The minutes. Do we have an agreement on the minutes? I was coming to that when I'd done that, but never mind. We'll do it. So, are the minutes correct, members? You happy with it? Right. And do we have apologies for absence,
yes, we do. We've apologies from Councillor Bailey, who's given other reasons, and Councillor Gordon Wheeler is substituting for him, and also apologies from Councillor McGrath, also given other reasons for apologies, and Councillor Pauline Allen is in attendance as a substitute. Thank you.
So, welcome to the two substitutes. Declarations of interest by members and officers. Disclosable pecuniary interests, anyone? No. And private interests. If anything comes up during the meeting, you can always declare it then. So we'll move back to this, which is, I was just actually filling in while Idris was here, but never mind. So in addition to the patients being moved to Sherwood Oaks in Mansfield, we understand that some patients will be moved to Highbury and some will be moved to Millbrook in Mansfield. And this move, as we found out at the last meeting, and the reason I'm saying this is we've got two substitutes and I want them to be fully aware of where we are. This move would have an impact on carers and staff in terms of travel. However, we are aware that the current Bassett Law wards do not properly meet patient needs, as there is a lack of privacy and little room for visitors within the mixed dormitory style wards. Facilities at Sherwood Oaks are planned to be superior, but of course the problem is it's a substantial distance from Bassett Law. At our meeting in July, we made it very clear and took a vote on our decision that without a travel package, we did not feel this move was in the best interests of patients. However, despite this, the governing board at Bassett Law Hospital took a decision a few days following our last meeting to move ahead with the planned closure. The key to the acceptability of these proposals is the development of individual family travel plans, which I certainly thought, and I must have misunderstood, was already underway in the planning. The proposed task and finish group will include carers amongst other key stakeholders. So I'll now pass over to Idris, who is here from Bassett Law, who will tell us why, as yet, there would appear to be no travel plan underway and why a request was made for further time to develop this. Thank you, Idris.
Thank you, Chair. Yes, I think hopefully, a lot has happened since we last met on the 13th of July. I'm pleased that we've now been able to make you aware and provide you copies of all the information with regard to the proposed change, which was considered after the last Health and Scrutiny Committee by Bassett Law CCG's governing body. So in addition to that, I'd like to go through the decision that the governing body made at that time and the reasons for that. And then we can talk about the task and finish group in terms of the development of the detail around the travel plans and then what the future timescales are. So I don't intend to go through it. I realise that there is a lot of documents behind the main paper that that you've received, but obviously we wanted to make sure that you had access to every piece of information, and it covers most importantly not just the engagement exercise and the results of that, and as we discussed at the last meeting of the Health Scrutiny Committee, I think the findings of that are clear. That the majority of people in Bassetlaw are concerned, quite understandably, about the transport and the accessibility of the new facility. I think a significant proportion of those outside of Bassetlaw recognise that actually that facility will be more accessible, but also there's a consensus that the current facilities based at Bassetlaw Hospital are inadequate. The engagement exercise also covered the planned investment in those areas that are being prioritised for investment in Bassetlaw for Bassetlaw-based services. That's £4 million over the next few years, and we're already sort of into that investment. And I think that's been very welcomed by all stakeholders and through the engagement exercise. It includes areas such as crisis intervention and support, postnatal care, suicide, children and young people support. So it is, I think, a very significant element to the strategy that we have. And I think one aspect of this that is important to note is that all too often, I think we talk about potential reorganisation because it's aimed at saving money and, you know, so reducing services potentially. But this is certainly not that. We would see an increase in the numbers of inpatient beds available for residents across Nottinghamshire, but also the investment that is being put in will benefit the vast majority of patients who receive mental health care, because as you'll perhaps have seen in some of the numbers, the number of patients that are admitted to hospital is relatively low, thankfully, and we do our best, both as commissioners and providers, to support people to, as far as possible, stay out of hospital, remain in their own homes with their family and their friends, and provide the support within community. And overall, there has been a slow, not steady, it goes up and down a bit, but there has been a reduction in the use of the inpatient beds. There's also information in the documentation about the Clinical Senate's view, which has been supportive, but also recognised the issues for the Bassetlaw residents around transport and accessibility. There's also letters of support from the Nottingham and Nottinghamshire CCG. And I think it's important, and I mentioned this last time I came to this committee, that I particularly welcome the perspective of the committee. I note from the papers that the affected councillors and wards were identified as the Bassetlaw ones. But I just wanted to reiterate again, when you look at the proportion of patients for older patients, 11.7% of the patients come from Bassetlaw. So 85% plus come from elsewhere in Nottinghamshire. The next largest group is from Mansfield and Ashfield, which is where the facilities will be moving to. And one of the single largest groups is Nottinghamshire City. I realise this is the county council, but the new facilities for those patients will be more accessible. So we, in the governing body meeting, had to consider not just the impact on residents in Bassetlaw and those patients. So 130 patients approximately for adult mental health in Bassetlaw and 65 for older people over the period of an entire year. To put that in context from a healthcare perspective, we had 217 patients go through the A&E department yesterday. But of those patients, we have 126 patients came from Mansfield and Ashfield for adult mental health and 44 from older people, so quite similar numbers. And from Nottingham City, 173, so the single largest group of adult mental health patients that were admitted into Bassetlaw came from the city of Nottingham. So again, it's just to reiterate that our governing body looked at this in its broadest sense. I think there is a consensus that the current facilities do not meet modern day standards, and that to bring them up to standard would require very significant investment, which is not available. And the investment that is being made, the £4 million recurring, will benefit thousands of people sort of a year, including people who currently may have been admitted to hospital that subsequently now, because of that investment, will be able to avoid being admitted. So the governing body looked at all of that information. I recognise not all of that was available to you at the date of the last meeting due to the timing of the different meetings. And it decided in principle to commence with the change, but it inquired in terms of the timescale of that and what further deliberation could therefore take place prior to any sort of commitment or any move actually taking place. The timescale for any move, the governing body was informed, would most likely be the spring of next year. So it felt that there was adequate opportunity, therefore, to look in depth and have greater involvement of stakeholders, the patients and the public, in terms of the detail of the transport plan. So in the documents that have been circulated, you'll see that there is a commitment and proposals around individual transport plans, but there is a greater opportunity now for that wider stakeholder engagement. And that's because the governing body takes this matter very seriously, I think quite rightly, and wants to see that depth of engagement on that particular issue, as opposed to sort of the wider engagement in terms of the investment and the potential change in beds. So the governing body has requested a full report to be brought back to its meeting on October the 19th, and it will consider, sort of that transport proposal at that point in time. The Task and Finish group has been asked to come up with the proposal by the 24th of September, so toward the end of this month. That should allow, sort of enough time for discussions with relatives to see what would be helpful, what would be, the most appropriate support that they would seek. It is targeted on the Bassetlaw residents because that's probably the greatest change. But we are mindful as well that although the access to the facility will be far better for the majority of patients, so 70 to 80% of the patients, it will be nearer and more accessible. There is still issues of transport, for other patients elsewhere in the county. So the decision for the governing body was to approve in principle with the proviso of the transport plan. They've also asked to hear more information in terms of what more broadly can be done to support patients, again, specifically from Bassetlaw. That includes the use of IT, sort of meeting people remotely through social media and things, and about how people who don't have access to that can actually be given sort of access and support. But also as well in terms of the so-called crash beds, so those patients that are requiring sort of very short support, sort of overnight or maybe 2 nights, about how that can be facilitated so we can retain sort of those patients in Bassetlaw, which is quite different from the longer term specialist support that most patients get, who are admitted typically for about a month to inpatient facilities and obtain sort of quite a wide range of specialist support, so distinguishing the different types of patients. The governing body also made it clear that they are very keen to hear the views of the Health Scrutiny Committee, and that was discussed, sort of in some depth, and it was a meeting in public, so that information is publicly available. And we were concerned in terms of the way that the timescales have fallen on this, and I've been asked to report back sort of the views of this meeting and what subsequently a final decision will be. And I note that the Health Scrutiny Committee is looking at what is in the best interest of all patients. I'd just like to assure the committee that that's where the clinical commissioning group starts and ends its views as well. It is looking about what is in the best interest of all patients, both within this facility and the ones that will benefit from the investment in the community services. We may reach different conclusions, I hope not, but I just wanted to reassure you that is also the aim of the Clinical Commissioning Group's governing body. And as you'll probably be aware, the majority of the Clinical Commissioning Committee's governing body are clinicians, so it is very much looked at from a clinical perspective. So I'll end there, and Chair, and just open up for questions if that's appropriate. Thank you.
Before I hand over to the committee, who I'm sure have got questions for you, can I just check two things? When we made the visit to Bassetlaw Hospital, we were told at the time that the patients from Mansfield and Nottingham choose to go to Bassetlaw so that they are not known, because they don't want to be known. And if you close Bassetlaw, they have no option but to go to Nottingham and Mansfield, where they may be known. So that was quite an important point, which Councillor Guilfoyle and myself picked up, that we were told they like to be away from the area they live in, for which I can fully understand. And can I just check with you that you said one of the considerations was to help people connect remotely? Are you referring to patients connecting to carers remotely? Because surely, if you're suffering from mental health, the one thing you need to do is to be close to your relatives, not connecting remotely. So can I just check those 2 points with you before I open it to the committee?
Yes, certainly, Chair. Unfortunately, I'm not able to be accompanied by the Nottinghamshire Healthcare Trust representatives, as I was at the last meeting. Although they did attend our governing body, so I've had an input into that, and there's a clash with their board meeting, so they may be in a slightly better position to answer your first question, but I will try. I mean, first of all, it is likely that that is the case. I'm not questioning that. I would probably raise a question about the proportion. I think it is highly unlikely, in my view, that all of the patients who come from outside of the Bassetlaw area do so as a choice in order to move out of the area. For the same reason why we're concerned about the move from the Bassetlaw residents going out of area, because of that access and access with family and friends who may want to visit. So I think it will affect some patients. It affects some patients who go out of Bassetlaw and don't get admitted in Bassetlaw, but they're relatively small numbers. So I'm more familiar with the patients who are admitted to other facilities from Bassetlaw, and there are some, but they are relatively small numbers in terms of the proportion of the people who are admitted. And I suspect that the Bassetlaw residents' views around whether they want to be out of area is not dissimilar to people, can't imagine why it would be, from elsewhere in the county. So yeah, I think it's a proportion, but I personally haven't seen the figures that would suggest that it's a significant proportion. There are other out of area facilities, so there are other potential opportunities for people who wish to move or be seen out of area to do that. But the other thing is that in terms of the Mansfield facilities, they would still be out of area for the vast majority in the county. By definition, because this is a county-led service, you want it somewhere in the county because that's going to be more accessible for the majority of people. So you don't want the facilities to be entirely outside of the county, but it's a big county. And therefore, some people are going to be living nearby and might have that concern. The majority of people will have some distance to travel wherever it is placed. So that would be my sort of view and reflections on that. Yeah, for clarity in terms of the remote connections, that would be to supplement face-to-face. It wouldn't be a replacement. Obviously, during the pandemic, we've had sort of access to many of our family and relatives, whether they're in care or not, entirely remotely, but that's not what we're suggesting here. It would be to enhance giving support to people to be able to visit sort of their family and friends if they were in hospital. But in addition to that, to give them greater access to individuals through the use of digital media.
Okay, thank you. I'll open it up to the committee now. Councillor Gowland.
2 points. I think many people have got experience of people going into mental health hospitals, know that there isn't really a choice, or at least I don't think often there's a choice. So when you say 11% of the beds in Basset Law are taken up by Basset Law patients, I guess my question is, what number of Basset Law patients have ended up elsewhere who would have preferred to have been in Basset Law? It's just because of, you know, which beds are free at that time means that that's the fraction you've ended up with, 11%. So if all the Basset Law patients who wanted to were put in the Basset Law hospital, what fraction of the beds would be filled? And the other thing you talked about, you want it to be in county because it's more accessible. But of course, in Basset Law, more accessible may not mean in county. It may mean out of county, and to what extent is that taken into account in this decision? And finally, just IT support. Presumably you mean allowing people to access IT by, for instance, going to the hospital and using Zoom from the hospital because they don't have access at home. Are you suggesting actively supported access to IT? Thanks.
Okay, thank you, Councillor. In terms of the number of patients from Basset Law that go to facilities outside of Basset Law, I don't have the numbers sort of readily to hand. I can provide them, but it's the minority of patients. And some of those patients, as you say, may not have a choice because of their personal situation and when they need admitting, and indeed where they may be at that time, which may or may not be in Basset Law. But another reason, a fairly significant reason for patients being admitted not in the Basset Law facility, but a Basset Law residence, is because they require a higher level of specialist care, which isn't available in the small unit in Basset Law. So I think that's more significant in terms of why they go out of hospital. It wouldn't take the usage of beds that much above 11%. It certainly wouldn't double it. So it is a relatively small number. In terms of those that go out of county, like I say, it's a large county. I'm not in a position to say where on the borders of the county all of the other alternative facilities would be. We can provide that sort of information after the meeting if you find that helpful. In terms of IT, what's been considered, and it will go into the task and finish group as well, is how best to support people with IT access to relatives who are in hospital or friends. That includes consideration of providing them during that hospital period with an iPad or something similar. So they don't have to go into Basset Law Hospital in order to contact their relative who's in Sherwood Oaks or Millbrook. They can do it from their own home. And that's what I mean by sort of trying to enhance sort of the access. And that includes, because obviously many people already have that. They have smartphones and things, but not everybody. And it's about filling that gap of those who have inequalities around digital access and what we can do to support those people.
Thank you, Chair, and thank you, Mr. Griffiths, as well, for your comments, which are appreciated. Appreciate that you set out that this affects a relatively small number of people, particularly if you compare to things like, as you did, the emergency services where you had several hundred patients yesterday, and this is just less than 100 in a year. However, I think the committee, in keep bringing this back to this committee, our interest is for the few. And as Councillor Gowland mentioned, for those of us that have had relatives and loved ones who've needed the services of acute mental health and that support, I think it's some of the most critical and the most pressing and the most upsetting in terms of the healthcare provision required for the individuals that end up needing those services, but also for the family members. And it's because of that this committee is taking this issue so seriously, and we keep coming back, even though it may actually be only affecting a very small number of individuals. And I think we will continue as a committee speaking for a very small number of individuals because we feel it's important. And I think the reason this also keeps coming back is the committee can see that for all the right reasons you've taken the decisions you have, but it would have been so much better if the travel plans for these patients, even though albeit a handful, had been put into place before you pressed on with all of the other strategic changes. Had that been the case, we wouldn't be sat here now and we wouldn't keep requesting your return to this committee. And I note that I think you mentioned that you now have a plan to put a travel plan in place and that there will be news on that from the 24th of September, if I heard you correctly, which is great news. But I also note that there's an awful lot of rearranging of the deck chairs that needs to take place across the whole county to facilitate the wider context of this, because obviously by moving the mental health services, that enables you to set up the emergency village in the facilities at Bassetlaw. I'm just wondering when the Sherwood Oaks facility will be open and when actually the mental health services will be moved. If we could have some milestones and a timetable so that the committee could have some reassurance that this travel plan will emerge, it will be credible, it will be tangible, it will be in place for the long term for these effective patients in Bassetlaw, so that we can have the reassurance to fully endorse and support your wider plans. Thank you.
Thank you, Councillor. There was a number of points there, so please do pick me up if I miss anything. In terms of the number, please don't get me wrong. Every individual, sort of is important, and it's absolutely right that we consider the matter very seriously, and there will be that impact. My reference to numbers is probably more in terms of the challenge around levels of investment and where you put, sort of that investment to get the best, greatest benefit to the greatest number of people. And that's where the £4 million investment, I think, comes in, which will benefit many thousands of people. So, yeah, I don't want to give the impression at all that, that we don't take this seriously for what is nearly 200 people a year. So that is not insignificant. In terms of the timescales and the transport, I'm quite happy that we could set that out. I think there's a couple of things to bear in mind. I referenced that we're looking really at the spring next year. And as you say, there is some link here as well to the other significant investment in Bassetlaw District Hospital in terms of their urgent care village. And there'll be a sequence to be followed, and I'll get more precise timings of this, because there will be developments, building works that are taking place both at Millbrook and at Sherwood Oaks, and they will have to be done sequentially rather than at the same time in order to not impact on capacity. And they're not insignificant sort of building works, but it really will bring both of those facilities up to really state-of-the-art standards. So that was one of the things that the governing body considered, was that because there will be more time than we'd probably first anticipated, because there was talk potentially of the move taking place this financial year or this calendar year. And that's now not going to be the case. It will be, I think, the spring at the earliest, as I understand today. And that does give more time to look at the transport plan in more detail, which is what the governing body wanted, in order to ensure that we could continue with these plans. And they didn't want to put more work into that prior to any move. So the other way around. They didn't want any move to take place before that detailed work had been done. And now we've got the time to do that. That's what they instructed their officers to do. I think in terms of that timescale, hopefully, if we can set that out for the committee and hopefully give sort of reassurances that no moves are going to take place before we've got a really robust transport and other support in place, we'll get back to where you're suggesting we ought to have been in the first place. I think the timings have just been unfortunate in terms of where the committee meetings have fallen for both our governing body, which obviously set many months in advance in the same way that yours are for this committee. But I think that there's no reason why we can't get to that position. I'm quite happy to set that out. Have I missed anything, Councillor?
No, that's very helpful. I think that perhaps some of our concern has just arisen from those the timetables and the way things have been set out at previous committees. The previous committee, I recall that information arrived very late indeed on the day of the committee, so we weren't able to make a judgment. So we just, any perception that maybe that the detail has been kept back from us would be greatly appreciated, with having clear milestones and timetables and steps going forward in the future.
Yes, thank you, Councillor. And I did point out at the last meeting that I regret how the meetings have fallen, but that is, like I say, it's a coincidence of the scheduling of meetings many months in advance, which are formal organisational board meetings, so they're not some meetings bespoke for particular issues. Hopefully now we've made available. And the reason you got it on the day was because that's the day it was published for our governing body. It was a coincidental date. As I said, unfortunate in that respect, but you have got every piece of information that I'm aware of on this matter.
But still no travel ban.
No.
Hi. I remain extremely concerned about the provision for those with mental health across Nottinghamshire, just in general. And without repeating what has been previously said, you mentioned the number 100. Mental health is on the rise across the country and in Nottinghamshire. And early intervention is without doubt stretched. People are finding it very difficult to access services, and the alternatives that perhaps could be offered are not being offered as it stands at the moment. I think we'd be fair to say that. Logically, this would point to the fact that this would result in more people with a high level of need that would perhaps access these exact services that we're talking about today. If there's no early intervention there, then it gets to the point where there's a high level need. So this 100 figure that you've talked about, I would be under the assumption that this would become greater, and this provision that you talk about, how is that being developed to cope with the rising number? I don't think it could be a rising number. There will be a rising number. So that's the first thing, because I can't see this anywhere. It seems quite fixed with regards to what is actually going to be delivered. The accessibility thing with regards to transport as well, when you say, oh, people in Mansfield will be able to go, it's nearer to them. I think where it's actually based doesn't necessarily mean it's actually accessible. So even if you're, as colleagues have said previously, or perhaps out of this meeting, if you get a train into Mansfield, then you've got to find another way to actually get to it. So it's not as accessible as what we thought it was. So the transport plan is actually critical to us here, to understanding actually how people can get there. And I think just to repeat as well, I do think we need to avoid these coincidental timelines, etc. as well, or the fact that we did receive the information at the meeting, I think was, like you say, does make it very, very difficult for us to digest the information on something that is actually so important to us. And last but not least, I'm still quite concerned about the document that I've seen about the current provision that's in place that I mentioned at the last scrutiny committee meeting. So for me, not only is it about numbers, but it is about the quality of service that people receive when they do actually go into into a hospital and access these services. I find it really difficult to come to terms with the fact that you say we're not doing it there because it doesn't meet the standards, when it hasn't been meeting so many standards for so long. I find that really frightening still, and I think keeps being glossed over, and we're not getting any answers with regards to that. When we looked at that document, the failings there were quite shocking, and I don't think that's a good enough reason to say suddenly we're going to close something and send them to this much better facility and everything's going to be great when they walk through that door. I think we need some reassurances that if that is going to happen and if that is going to take place, that the quality is going to be there for those people. And last but not least, I do know that it's a huge challenge with regards to, as I've said previously, about mental health at the moment. It is on the rise, and undoubtedly we do need more early intervention available for people to avoid and help people before they get to that point.
Thank you. Just a minor thing, but in terms of the numbers, I think the numbers I quoted for Bassett Law residents was 133 adult mental health patients and 65 older people, so just over 200 in a year. That's the last full year of figures. There's more detail in the papers on that, though. I absolutely agree in terms of early intervention and the rise of mental health problems. I'm very pleased that we've been able to meet the mental health investment standard over the last couple of years, and we're planning to do that. And that the £4 million investment will also address a lot of the issues that were in the NHS forward plan about the equity of esteem on mental health. So that goes beyond the mental health investment standard. Our access to many services at the moment, and we would always like to see them better, but things like IAPT are some of the best in the country at the moment. But the growth of mental health problems, for example, within child and adolescent mental health problems, which has got nothing to do with these inpatient beds, because this is sort of adults and older people. It is one example of the area that we're putting in significant investment to support people. And that can impact on not just the period of illness whilst they're younger age, but it can last for many years into adulthood. So that I absolutely agree that early intervention is so important. Hence why the investment of the 4 million is in local community-based services. As part of that investment as well, just as an aside, it includes more than the services that Notts Healthcare provide. So we're also working alongside the community and voluntary sector and organisations like Mind, for example. Some of the grants that we've issued just within this financial year have been important because we've involved people with lived experiences in order to identify where those grants should go into local community voluntary services. So we're very keen to make sure that we address those needs as you've described. In terms of the standards change quite rightly over time, and expectations change over time. And sometimes that impacts on every public sector organisation. I think it reflects on sort of accessibility of buildings for people with disabilities, for example. It's taken years for some buildings to either come up to standard, and recognition that sometimes, it actually means that you need to move into a new building, and that takes time. The level of investment to bring the current wards up, and the hospital's not that old in Bassett Law, is it? There are many other hospitals that I think struggling far more in terms of the quality of their build overall. And when the mental health wards were first opened in Bassett Law before my time, I suspect that they were well received in terms of the standards of the facilities expected at that time. But they are well below standard now, and below our sort of current modern day expectations. We've described things about single-sex area and dormitory-style accommodation, things which really are not acceptable, but not easily resolved. And my personal view, and I think this was supported by my governing body in the round in terms of the new facilities, is that this is the best opportunity that we have to provide high quality facilities. In terms of access, there's two hospitals that we're talking about in terms of the new facilities. There's Millbrook and the Sherwood Oaks, and I accept the point that they're not equally accessible. And the Sherwood Oaks one, which would be a fantastic facility, but has got transport, sort of issues, and that needs to be taken into account by the group that's going to be looking at transport.
Yeah, thank you, Chair. Yeah, I mean, it's a very complex issue, and it always looks on the face of it like Bassett Law always gets the rough end of the stick, because obviously services have been cut in different areas, and it's always perceived by the public as a cost-cutting exercise, really, on behalf of the hospital itself. But in reality, I believe the CCG has taken the right approach in recognising the fact that the current facilities are understandard, and you have taken the right approach in investing in Sherwood Oaks, because that's expanding the services almost geographically in the middle of the county, really. So that's a lot better for people from the city. And I take on board what Councillor Barney says about the travel packages, and that is a consideration. So out of the 200 patients a year that receive mental health care, how many are acute that need to go to Sherwood Oaks out of that 200? Because that puts it more into perspective. And I think anybody going to Sherwood Oaks from anywhere in the county wouldn't be recognised, because it's sort of like on an industrial estate along, you know, so the talk about people wanting to not be recognised and being moved is just a lunacy to me, really. I know we're going to get an increase in numbers of mental health cases, but I do think from the clinical commissioning group's point of view, they've taken a proper approach in expanding mental health services in the right area. It's only the same as rehabilitation that we're talking about moving to Stamford Hall. You know, so we're taking services out of Mansfield and placing them in Stamford Hall. It's just the same kind of thing. Access is always going to be an issue. And as far as IT is concerned, surely that's just going to assist people. And COVID has exacerbated the use of that in tenfold. You know, so people accessing mental health patients, if the new facilities are going to provide that as standard, then that's better than they had before anyway. It's a leap forward. So, you know, I think it's a very difficult thing. And so long as they can address for the few who can't afford to get there or can't get there under their own steam, travel packages, that's all we sort of need to finish the deal off, really, because it's a massive improvement in mental health care services across the county, not just in Bassetlaw. Thank you, Chair.
Just before you answer, Idris, can I just put a point straight with Councillor Martin? Councillor Guilfoyle and myself made that visit to Bassetlaw. It is not a lunatic suggestion, either from myself or from Bassetlaw. That was actually mentioned by the doctor who showed us round Bassetlaw. And to prove it, I went around and actually saw somebody I have seen. She was embarrassed, I was embarrassed, I looked no further. So what I was told, I can firmly believe, and I don't consider it's a lunatic idea. And to use that phrase under these terms, I think is unnecessary.
If I could address the other issues that you mentioned, Councillor, and I think the other points you made are obviously the things that we've been considering very carefully in terms of how do we have the greatest impact and the greatest benefit to the greatest number of people. And we've described it, again, in terms of the numbers, around about 200 patients from Bassetlaw are admitted to Bassetlaw beds, nearly 700 from elsewhere in the county. So that's the sort of proportion. So you can see in terms of just numerically the number of patients that will be benefited by some much higher standard facilities. And I've mentioned before that we're talking about single rooms with ensuite accommodation. And part of the issue that we have with the Bassetlaw accommodation is dormitory style accommodation and lack of privacy in your own space, which is what the new facilities will provide. And I think, Councillor Chair, your experiences, and I think your visit along with Councillor Guilfoyle's visit was very welcome in terms of how seriously you're taking the issue. But you'll have seen the problems in terms of privacy in the current wards, and you can understand why some people would find that very awkward, because you just don't have your own physical space, and you can't easily go outside to get a bit of fresh air and get the sun on your skin. Yeah, so the new facilities will address many of those issues, and hopefully, sort of make people's sort of not just the clinical experience, but that physical experience, sort of much more enhanced. And as a layperson, not as a clinician, I would suggest that both of those things go hand in hand in terms of mental health. It's put people in a facility where they're feeling awkward potentially at times, not having their own space. People with what we call organic versus functional, so people with dementia versus mental illness sharing the same space, is just not ideal. And the new facilities would address all of these issues.
Thank you, Chair. Yes, if the facilities are moved to Sherwood Oaks, and it does look very much like that's going to happen, the issue that we need to sort out, or your needs to sort out, is the transport issue, which is absolutely abundantly clear. The travel plans, if the family travel plans are put into place, will that be a permanent measure, or will you review it at certain times on that issue? And you put on your in here it says that you're going to engage with a number of groups, etc. I just what kind of involvement are you having with the groups, with the organisations, with the carers, with so forth? I'd love to know what you're actually doing about that. And of course, one of the things that's not been mentioned too much is the staff. What facilities are you going to provide for the staff, or will they be have the opportunity to engage with whatever transport you put on? And wouldn't it be a good idea, and I don't know whether you're going to do this or not, is to put the tender, but to put the transport issue out to tender? Whether there are a number of large taxi firms that will, if they know they're going to get a lot of business, they will reduce the prices. And you know, it's absolutely essential that you get the best service for the cheapest price, and so forth. So, did you say that there is going to be a local crash bed service? I think you said that that's a possibility on a few of cases. And if you could answer that one for me as well, that's very nice of you. Thank you.
Many thanks, Councillor. So, in terms of are the arrangements expected to be permanent, they are expected to be permanent, but of course they'll be kept under review. And if, for example, they do go out to tender, there'll be a contract associated with that. Personally, I think it's important that we lock this in for the long term. So most contracts run between 3 and 5 years, for example. So you know you'd want something that gives people confidence that that those arrangements are going to be around for the foreseeable future. In terms of the patients and carers, we're taking the lead from the provider, from Nottinghamshire Healthcare, in terms of involving both patients and carers and representative organisations of people with mental health problems. And they've got, I think, really good access and involvement and engagement with people. So these are people, again, I'll come back to the sort of point I made earlier about other investments that we're making. We're very keen on making sure that we talk to people with lived experience so they can input into that and have the confidence about what the plans will be. I'm not on staff, I'm not leading the discussions with the staff, so I can't answer that without my Nottinghamshire Healthcare colleagues. I'm sure they are, but we can provide perhaps further information on that to the committee. No, I can't. We've mentioned staff on many discussions outside of the decision about move, but it's for the provider to really lead on that rather than the commissioner. But our expectation is that there will be full consideration of the impact on staff and the support that they need. And on the crash beds, it's the hope and expectation. These are relatively small numbers of people. So they, out of the numbers I've described that are admitted to hospital, most of those are long-term admissions. But I think the point has been made previously that it's one thing if you're remaining in a facility for a month, for example, not going backwards and forwards and so with that sort of disruption, versus actually you need somewhere that's safe to stay overnight or maybe 2 nights. So there will be small numbers, they always are for those sorts of facilities. It's not been identified exactly where that would be, what that would look like. So that's one of the things that the governing body has asked for more information on, and the provider is looking at the options with regard to that.
Yeah, yes, please, Chairman. Thank you. And thank you just for coming here again. I think I said it at the last meeting, I really support the fact that we've got the £4 million worth of investment over the next few years to improve the services out there, which again, will I'm sure bring out the hidden amount of people who are suffering from mental health, which in that short to medium term will increase, I believe, the impact, as my colleague says, on services both locally and wherever else they remain. Just in relation to our visit that took place. You know, I have to concur what was said to the chairman. You know, at the time, I made notes about that as well. You know that. But what I would say is that, you know, on reflection, I've sat back and thought about that visit and about what I saw. And in reality, when you put pen to paper, it was shocking, really, if I think about it and think about the fact that if I'd got someone, although I have known people who obviously locally, but if I'd got someone as well who was having to actually be in those conditions because of where they are, because of the lack of access to an outside facility where they can get some fresh air, as you said, because of the way in which, you know, the mix and mix of patients, etc. So it did take me aback, you know, and understand quite fully the need for that change to happen, that for the facilities that are needed need to be quality. The disagreement I've got is that I think that facility should be provided within the Bassett Law area, and I still believe that, and I think that could be done, in particular for the elderly. It was mentioned to us at the time of the visit about a partnership, perhaps with other providers of elderly care within the area, could have been looked at in more detail to see whether the elderly could remain locally. I think it's not more important, I think it's as much as important for anyone if they wish to remain locally so that they're near to the loved ones they can. But I think it's even more when you look at the figures. I mean, anybody knows who looks at the number of people who are moving to care homes and the length of time, usually, you know, within 6 months, a number pass away. And some of that, I believe, is down to the fact that they're not near and have that constant presence of their families and loved ones around them, which they probably would have had if they'd been living with them or they were near to them. So the same again, you know, what, by moving people from the area, you're making it, in my mind, doubly difficult for them. And I think that a facility could be found, in particular for the elderly, very quickly by working with another provider to deal with that particular aspect. I'm upset in one sense because, you know, as you say, that facility has not just gone down overnight. That's happened over a period of time. And I accept what Idris says, you know, if someone walked around here today, they'd find something that was wrong in health and safety terms and say perhaps it's not fit for purpose because of A, B or C. And I understand that, you know, that's the world that we live in. Things change and you have to modify to that. And sometimes it comes to a point where you can't just titivate. You've actually got to spend some money, and I can see that time has come. I think one of the problems is that that's come at the same time as the hospital has got other plans, which they need to do. So again, that means that you've got to move out of that facility anyway. On listening and reading some of the stuff about where people say it's best, I've got a concern that we're actually creating a big facility in the centre of the county, and big is not always beautiful. Now I know that they can compartmentalise those services, but it will be in one area, which then leads them to be where there's an opportunity for you know, staffing reductions, etc., because we can manage it because it's all on one site. So I have a concern that is going to be managed in the future. In relation to currently, I've also got a concern currently about the people that are using those facilities. So I don't actually think, you know, I have to agree with you, it's not fit for purpose. And in one sense, you know, I would say that we shouldn't be admitting people there, personally. And, you know, so that's a big concern for me at the moment. I would like a report to come back for members actually about the crash beds, because I think that is a major issue, because of the fact that no one ever knows when people are going to be struck down by a mental illness, and that facility for me is probably the first part of someone in a serious phase. They need that facility there, and I would like us to sort of have an overview of that and watch how that develops and ensures that we have sufficient creche facilities available for Bassett Law residents locally. In relation to the travel plan and the group that you're formulating to work on that, I would also like to suggest that perhaps we talk to our transport colleagues, because I noticed that, yeah, you've got a lot of groups, but perhaps one of our county council professional transport colleagues ought to be added to that list, because they know all the routes, they know all, and they're also responsible for timetables. And it may give them an opportunity to look at that and assist in making sure that any transport plan is really fit for purpose. I'd also like to pick up on the fact that Hydra talks about the 3 to 5 years, and unfortunately in this day and age, even the CCG can't say it's going to be here in 3 to 5 years. Next week there'll be another government white paper that says, oh, we don't need that anymore, we're going to do this. And unfortunately what happens then is a lot of those plans that you put in place get lost as well. And we've all been there with this. Oh, well, that was the previous Labour council, that was a previous Tory council, or that, whatever else, and it doesn't matter anymore. This is too important to allow for that to happen. And I'd like to see a longer term look. The health service has done 10-year plans for things before. We've all seen 10-year. I'd like to see at least a 10-year plan on the transport strategy, a longer term. I'd also like to see some of the voluntary sector transport users, as opposed to private companies, some of the voluntary sector transport enabled to bid for this. But also, if it was a voluntary sector, and there are some voluntary sectors within the Bassett Law area, that is ring fenced to them with proper terms and conditions over that 10-year period, which would probably give that voluntary sector group some sustainability as well in the long term, rather than sort of saying, well, we're going to give a taxi firm, some sustainability. Let's give it to a voluntary sector group that is providing that. I know you work very closely with some of the voluntary sector groups currently, but to actually give them that as an amount of money, earmarked, future-proof for a longer term, would also guarantee that service for the public. I think in another 3, 4, 5 years, yes, you will be able to rely probably a little bit more on people using internet and iPads, but there are still a significant number of people who find it difficult to do that. I don't think that we should be getting solely reliant on it. There is nothing like a face-to-face conversation with people. Yes, we've all got used to using internet from home, but there's nothing finer than being sat here and seeing your address and being able to have that conversation. So still got very big concerns. Still think it's the wrong move, ultimately, for the people of Bassett Law. Accept what you're saying about, I also think it'd be probably a wrong move for some of the wider communities as well, because they'll struggle to get there, as has already been said by Michelle. I can see people from the other end at Broxtowe having trouble to get to some of these places, as well as people who live in the Bassett Law, or even Newark, getting to some of these places. What's the transport plan for them as well? Not just so. Think that really does not just for the Bassett Law, the whole of the lot the transport plan needs to be looked at. And I still think there is an opportunity to look at the older people in another way. And I know that means money, and I know it means investment, but they're worth it, aren't they, at the end of the day? And I don't think just plucking a super duper place in the middle of the county will benefit any of them. Thank you, Chairman.
as much as I can remember. I was trying to make notes. Thank you, Councillor, and thank you for your sort of very considered and balanced, sort of views, and certainly I respect, sort of where you're coming from. We may disagree a bit on the final solution, but I think we're sort of very much in tune in terms of what the issues are and giving those all serious consideration. Yes, the crash beds, like I say, is something that our governing bodies said that they're also interested in. As I mentioned before, they're relatively small numbers, so patients are not typically admitted at the moment into Bassett Law for that short-term sort of care. So it is a little bit different, but still important for those sort of people nonetheless. I think this wider issue about how we support people, particularly the older people, potentially with dementia, it's interesting, isn't it, to reflect that today is probably that's the top thing in the news in terms of social care and how we support people, sort of with dementia, for example, because it's not considered a health care, sort of service supporting people, so with dementia. So I won't get into the politics of self-funding and things, but I think obviously there is a national desire to try improve and support, sort of older people more broadly in a better way, and I think that will have, sort of, and it is relevant, but hopefully will have really positive consequences. So I welcome the fact that other people are struggling with that very difficult matter, but I think it's one that needs to be addressed. In terms of organisations come and go, well, you're probably aware that the CCG is likely not to exist in 7 months' time. So difficult for me to give absolute assurances when my organisation's not going to be here at the end of March. But I agree that how we can lock this in, and if it is, for example, a tender and a contract, that we look at a longer period of contract rather than a shorter one. I think your point about the community and voluntary sector is a really interesting one. So I'll balance my line here, because there are procurement rules, and then there's what we sort of are hopeful that we will achieve. And certainly I think that the public sector purchasing services from local organisations, whether they be private or community voluntary sector, but for the community and voluntary sector, where it gives them some long-term security in terms of the money that they need in order to run the services. And we do invest fairly heavily in the community and voluntary sector in Bassett Law, including on transport, interestingly. So there may be opportunities there, but I am an advocate of supporting local businesses as well as local community voluntary services with public sector money. I think there's a lot that we can do to support the local economy, support sort of people having greater opportunities to have paid employment and so on. So we'll certainly look at that very seriously. In terms of the digital, I think we've tried to address some of those issues. It's not a substitute for face-to-face. My father would agree with you absolutely that he's a dab hand at iPad now, so, and that you could do FaceTime, sort of like as well as anybody, but it's not really a substitute, and it hasn't been, sort of for many months now. But it is a really useful addition, and I think in terms of how straightforward some of that technology is now, it didn't take me long to get an iPad into my father's hands and get him using it. And it can be made available to more people, but not everybody has got physical access to it or can afford it, and it's about how we support people in that. But it is an enhancement, not a replacement to face-to-face. Have I missed anything, Councillor, that you wished me to?
Well, what about the concern I've got about the people that are in the existing premises as it is now?
Yeah, absolutely. Yeah, I think changing, as you said, we've gone beyond the point where you could tinker and sort of do paper over the cracks in terms of the facility. I think the staff do a fantastic job, and I think the care that people are receiving, and indeed their experience, despite the quality of the physical facilities, is still very good. And we've had direct approaches from sort of ex-patients saying how much they valued that, and they'd actually in some cases put that over, you know, sort of the quality of the physical service is the quality of the care that they've received. We do limit the provider limits the numbers that come into certain things. They try and keep that sort of segregation and privacy as much as possible. They'll continue to do that, and they'll continue to address any problems, you know, sort of with the building. But I don't think there's a short-term fix because it does require significant capital investment. So that leads us back to, well, how quickly can we get a new facility up and running? I've talked about the timescales for that, but I think the staff and the service are doing all they can in order to ensure that there's the highest quality of care that there possibly can be in that facility. And I still think that is a high standard of care.
Care side, I'm not criticising the care side. It's the physical environment. But that does impact on how people feel.
Yeah, there's a personal reflection on this. And I've been in the health service well over 30 years. My first job in the health service was in a large psychiatric hospital. It had another name previously, but I'm not going to use that. That facility was a legacy from the Victorian era and had very large sort of Nightingale type wards, locked facilities. At some points in the past, it also had its own football team and farm and things. You know, it was a huge facility, but yeah, times have just moved on so much, and thankfully so. And you know, what I saw 30 years ago is probably now what you're now thinking. Well, the current, you know, sort of problems that we've got, but we have progressed, you know, sort of quite considerably over the decades, and hopefully we'll continue to do so. And I think particularly around mental health, which has been called, you know, the Cinderella service in the past. You know, it's not had historically the investment that it needed, nor historically, going back to when I first started in the health service, the type of care that was really appropriate. So I'm just reflecting on the fact that, yes, it isn't appropriate, that facility now, but time is caught up on the building, and it takes a bit of time, unfortunately, to address that. But that's what we're here for.
Sorry, it's really quick. It came from a comment someone else made. We've been talking about travel plans for the people of Bassetlaw, but of course Bassetlaw Hospital has an area around it which it serves. So presumably these plans would be accessible to everybody from the north of the county. Okay, thank you.
Right, well, thank you, Idris, for answering all our questions, but I do have to say, I don't think we're still resolving them. The issue with me, I concur fully with Councillor Guilfoyle. He and I made the trip, and it was quite an eye-opener. The issue with me is not the fact you want to move the people, because gracious me, they should have been moved years ago. And I think you were forced, in a way, to think about a move when they said that they wanted the mental health building to be an emergency, accident emergency building. It made you think, what can we do? And we'll move. And I can appreciate that you want to move to modern facilities, and I don't have an issue with that. But I do think that probably the governing board did not take the opportunity to look around Bassetlaw and see how you could alter things there. I think I tend to feel like Councillor Guilfoyle, it was a slightly rushed job when you were told you had to move. And I do think more time and consideration should have been given to providing, albeit only a small unit in Bassetlaw, but somewhere where somebody can go for 2 nights, if necessary, instead of being hoiked off to Mansfield or Nottingham, which I think these people are vulnerable. And I think when they're vulnerable, it's a terrible situation to be taken well away from the people who love you. So I would have liked to have seen that you'd put some consideration into a small unit in Bassetlaw, as Councillor Guilfoyle has alluded to. The bottom line for me, and I'm sure all members of this committee, is the travel package. Without a shadow of a doubt, these people are vulnerable. They may not have transport. They're taken away from their loved ones and they're stuck, absolutely stuck. And I don't care what anybody says. In these financial times, if it becomes too expensive to transport people, that will be the first thing that goes. You know, that's if we get a transport plan, because in actual fact, there's only 2.5 weeks left to put this transport plan to the governing body. And we've already been waiting for this for 2 months. So I'm beginning to wonder if it will evolve on time. You've mentioned that the visual contact is a useful addition, and so it may be, but in no way is it a replacement for a face-to-face hug with your relative, I'm sure. And I think there's been a speed to remove from Bassetlaw without consideration to providing a small unit. And I think that's a great pity for such vulnerable people. However, as they say, we are where we are. We still don't have a travel plan. And I, as chairman of this committee, cannot still agree to the move without knowing that there's a travel plan. Now, it does become available to your governing board on September the 24th, am I correct?
That's the date we've asked the task and finish group to come up with a plan. It's not the date that the papers will be made available to the board.
So what date will the papers be made?
The papers of the board are issued at the beginning of the second week in October. So there'll be a couple of weeks to finalise the plan that comes out of the task and finish group. Because
this committee can't make a decision until we know. Now, our next meeting's the 12th of October.
I had requested that we could be on the agenda. I understand the agenda is a very busy one in October, but I'd made that suggestion previously.
Right. Well, all our agendas are very busy, not with no exception to the October the 12th one. But I would ask that you come back to the October committee, please, with the details of a permanent travel package. And then I think you will get support from this committee, apart from the fact that I think there is still time for someone somewhere in your establishment to see if there's a way of providing a small facility. And I realise you haven't got the experienced people in a small facility, but you have got somewhere where somebody is in a safe place for a couple of nights being looked after while you decide their future, instead of taking them across to Nottingham or Mansfield. It may be that they could go home after a couple of nights, but the stress of moving these people away from their family, to me, is just not acceptable. So I would ask that you come back in October with those details, and perhaps in the meantime, see if there is any unit, as Councillor Guilfoyle has asked, to put these vulnerable people for a couple of nights where they're not being taken away from the people that care for them. So I do thank you for coming. It's been very valuable. I'm sure you feel you're being taken through the mill. But this is a very, very important thing to the committee, because it is on the rise, mental health. And as a matter of interest, in October, we start our mental health programme, and we will be looking into all types of mental health. So I'm sure we shall be seeing you again even after October. But with the committee, I would just like to take a vote, members, because I feel we need to make it very clear to Bassetlaw Hospital that we still do not have the answer to the travel package. And because we don't, we can't support the move until we do. So can I have a show of hands on that, please, if you agree with me? Yeah. Well, they can still take the plan ahead, but they will know that the Health Scrutiny Committee has not approved it. And we will forever be watching Bassetlaw Hospital. Yeah. Yeah. So can I take a vote, members, on the fact that we need to make it clear to Bassett Law Hospital we still can't support their programme because we don't have the very thing we need, which is the travel package? Show of hands, members, please. Thank you very much. It is unanimous. So you are having a meeting with your governing body. Please will you take those thoughts back to them? Thank you very much, Idris. Thank you.
It's a chance to leave and we'll get the next attendees in.
Yeah. Don't rush, Idris. I'm sure, you know, it's a hot day. We haven't finished, members. I don't. Oh, right. No, I'm all right, thank you. Don't want everybody to disappear. Thank you, Idris. Thank you. Are we stopping live streaming for a couple of minutes? Yes, thank you. Thank you. Right, good morning to our visitors. All right, good morning to our visitors. We have Lucy Dodge with us, who is the Chief Commissioning Officer. We have Joe Lunn with us, who's the Associate Director of Primary Care. And we have Dr. Trimble, who is the GP representative with us. So here we are, members. Every member in this authority has a question on primary care, but as you can see, there's only about 12 or 15 of us here. This is a very, very hot topic at the moment with our residents out there. And so thank you very much for coming in today. We have a real area of concern over primary health care. So it's over to you, Lucy, really. I'm just welcoming Councillor Richard Butler, who asked if he could join this committee for this discussion. He's not actually a member, but he's here and he is allowed to ask you a question if he has one to ask. So thank you. Over to you, Lucy.
Thank you.
Sorry, Chair. I understand, is there some difficulty with the presentation that you're hoping to share?
It says that it won't let me share. It says organisers and presenters can share, but the button is blanked out for me.
Noel's our expert. Can we pause Stuart a moment, please?
Chair, while we're waiting, can I just briefly introduce what we're hoping we can do today? So,
Could we stream again, please, Stuart, because Lucy is going to speak. While we're waiting, Lucy's going to speak. Are we streaming now? Thank you.
Thank you. So I just wanted to very briefly introduce what we're hoping to achieve today. So thank you very much for asking us to come today. We see this very much, I hope, as the beginning of a dialogue. As you know, the provision of primary care services is something that's fundamental to all of us. Every patient, whether you touch other healthcare services or not, every citizen will be registered with your general practice, with a general practice. So this is an absolutely key part of our role now and going forward. So we're going to go, Joe and Ian are going to take us through the presentation. You've had a background paper, but I just really to say we are very happy to take any questions, and we would also be very happy to provide any follow-up information that you might require. So I'm going to hand over to Joe.
Thank you, Chair. So hopefully you've all had the briefing paper that came out to yourselves, and obviously we've now got the brief presentation in front of you today. So thank you for having us. As Councillor Saddington introduced, I'm Jo Lunn. I'm the Associate Director for Primary Care for Nottingham and Nottinghamshire. So we'll quickly take you through our slide deck and then leave plenty of opportunity for questions for you all, because I'm sure you've all got plenty to ask us today. So a little bit of an intro into what we're going to take you through. So the contract, our quality outcomes framework, enhanced services, workforce, how appointment data works for us, what monitoring we can do and what monitoring we do, the regulatory roles and some of the assurance, booking routine appointments, and then obviously I'll open up to the floor. Okay, so across Nottingham and Nottinghamshire, we've got 140 practices now that we're starting to come together with Bassett Law. So we were 125 as Nottingham and Nottinghamshire previously. And across that spread, there are 47 in the city, 39 in Mid Nottinghamshire, 39 in South Nottinghamshire, and then the newly coming together with Bassett Law of the additional practices. And our contract mechanisms for general practice come into three forms. So we have got general medical services and personal medical services, which are contracts that are in perpetuity and ongoing contracts. And then we've got alternative provider medical services contracts, the APMS, which are time limited contracts that we have in place for those more newly commissioned services that we have. And each of those contracts consists of a couple of elements. So the core elements of the service, which are provided between 8 and 6:30 Monday to Friday, a quality outcomes framework, and then enhanced services that are either commissioned at a national level or locally for our population in Nottingham and Nottinghamshire. So a little bit more about the quality outcomes framework. So it's a voluntary scheme, but it's a reward and incentive programme that's offered to every GP contractor with the aim of improving the quality of care for patients and trying to ensure a standardised delivery service across primary care. And there are indicators across the 4 main components that I've outlined here and in the briefing paper for you. And it's based on delivering a range of those clinical targets for patients. Enhanced services, as I mentioned, we have some directed enhanced services which are offered from the national level, and then we have locally commissioned services. And I've included in your briefing paper a rundown of those enhanced services that we support within Nottingham and Nottinghamshire. So we have an enhanced service delivery scheme, which includes things like our phlebotomy services, some of the treatment room, and some of those more operational services. And then we have individual specific enhanced services as listed down to support patients that may have certain individual needs or conditions that need to be supported. And then we have the introduction in 2019, nationally they introduced a primary care network contract DES, which is where our GP practices start to come together to work as primary care networks and groupings of practices working together on behalf of neighbourhoods, populations that they serve, and supports offers around improved access and extending some of the range of services and the staffing structures within those to support the patients with wider health needs, and linking in with the wider community services, mental health services, and some of those third sector organisations to deliver services along with community pharmacy, etc., on behalf of the population. And some of those services started to look at digitalising and changing the way that access support was available to our patient population. So patients having access to online records, being able to have rights to online and video consultations, booking appointments, extended hours access, so services outside of that 8 till 6:30 time. So quite often they are early mornings, evenings or weekend appointments that are offered over and above those core services for general practices. And then being able to book directly book through 111 appointments with your general practice if you've entered the system using the 111 route. For workforce, obviously one of the contractual requirements of our general practices is that we monitor workforce, and there is a national system, the NWRS system, the National Workforce Reporting System, where practices have to input the number of staff in across all clinical groups. So they put numbers in terms of the full-time equivalents and the head count in terms of both GPs, nurse, other staff where we have direct clinical input, and the administrative staff supporting those services. And then we've included the link within the brief to give you a little bit more information around that service. Moving on to appointment data, one of the contractual requirements of our general practices is that they allow data extraction to be undertaken to pull out the number and the types of appointments held and offered. And our colleagues in NHS Digital do that extraction on our behalf. It's not something that we at the CCG deliver, but that is a requirement of our general practices. But unfortunately, it's also something that we don't have access to in terms of individual specific practices, neighbourhoods or PCNs currently. So the data that we get back from that is aggregated currently at Nottingham and Nottinghamshire CCG level. And once the move to Bassett Law's partnering becomes available, we'll also have that information available as well. The latest information we've got from that extraction is for June 2021, and we're starting to see the number of appointments delivered on a monthly basis is increasing, with over 500,000 appointments delivered in June, and 57% of those now being delivered as face-to-face appointments, and over 50% of those being delivered same day or the day after. And you'll be able to see from the graph on the right hand side of the slide, we're gradually starting to see that upward trend in activity. So monitoring, so what can we monitor, what do we monitor? So we don't, as we don't have access to individual general practice appointment data, we can't monitor at an individual practice level the number of appointments and the types of appointments currently going through. We are trying to make waves and push for that data, but at the moment we haven't got access to that, so we're not able to do that. But we do get data back from the National GP survey, and we're starting to see that an analysis being undertaken based on the latest GP survey results. And what we've put in your little briefing for today, and also on this slide, is where we are as Nottingham and Nottinghamshire against the national average, and you'll see that we are slightly above national averages right across the 4 categories we've pulled out for you. But there are worst and best in every average, and we appreciate that for some practices that will mean that they are clearly higher than the average, and for others there are lower, and we've put in our best and worst there for information for you. At the CCG, we do have a quality dashboard, so we try to monitor wherever we've got indicators that we can monitor against, and to try and help provide support across our general practices to try to facilitate some of those improvements where we can. So obviously we link quite closely with colleagues from the CQC around the ratings, particularly around the 4 domains that they respond to, but they're also around overall ratings for our general practices. We look at clinical outcome measures, so where we can review activity levels against targets such as immunisations, flu and screening numbers. We include those as part of our data dashboard. Patient experience, so some of the friends and family national survey information. Whilst obviously we've been in COVID, some of the indicators have been paused, so we know that friends and family has been paused as an option during the COVID status. We will expect that to start again at some point soon, and we can start to measure some of that. But we also take into account patient feedback and things that come through our patient experience team in terms of concerns raised, etc. And we look at patient safety issues around policies and safeguarding. And we regularly monitor this across both primary care and quality teams. So we wanted to give you a little bit of information about the roles today. So obviously NHS England are responsible as the organisation for provision of high quality primary care services right across the population for England, but Nottingham and Nottinghamshire has that delegated responsibility for commissioning of the primary medical services, which means the CCG has that full responsibility transferred to us for the local population's general practice services. But NHS England do still retain dental, optom and pharmacy services, but we have close links with our colleagues there when questions come into us about services that are outside of our delegated responsibility. And then other key organisations as part of that regulatory responsibility are Care Quality Commission and our colleagues from Health Watch, who we work very closely with. So booking a routine appointment. So we thought it was really important today to cover off that during COVID times, as we all know, things have changed for many circumstances, and that includes how we book routine appointments in general practice. So during the pandemic, face-to-face appointments were and have continued to be based on clinical needs, and telephone and remote triage arrangements have been in place where patients are contacted firstly to see if their needs or conditions can be met via a telephone or remote video consultation, and being brought into practice wherever there has been a need for face-to-face identified as part of those reviews and triages. And that has been the case all the way through. So wherever there's been a clinical need for a patient to be seen face-to-face during the pandemic and up to date, then that is happening. And currently data is showing that we're seeing an increase in the number of appointments provided, so higher demand now than previously offered at 57% and 50% of appointments same day, as I mentioned previously. And then nationally, they've recently carried out a survey, a review to look at what access patients are getting from, are being able to access in terms of the turnaround times for non-urgent in-person face-to-face type appointments following triage, and then those that are awaiting phone and video consultations. And the numbers that we're being presented with nationally are 8.7 days for an in-person appointment and 7.4 for a video or phone consultation, which compares to an average wait time pre-pandemic of 2 weeks. So as you can see, we're starting to see improvements based on the pre-pandemic levels, as well as we move back to recovery. And the data that's provided in your pack shows the national numbers that we used as part of that. So just to summarise, CCG is responsible for commissioning general practice on behalf of NHS England, and we monitor delivery against nationally negotiated elements of that GP contract, and wherever we can, quality indicators as well. Public demand and satisfaction with general practice remains extremely high, but it is recognised that patients have reported difficulty on occasions accessing services, particularly during the pandemic stages. But that isn't unique to Nottingham and Nottinghamshire. That is something that was being experienced right across the UK and England. As well as monitoring the practices, CCG is offering resources specifically targeted. So national funding's been made available for general practice, specifically targeted at increasing workforce capacity wherever we can, and to improve resilience within general practice. Because as we know, workforce in general practice is also sometimes impacted by sickness and sometimes COVID related as well. So that hopefully starts to help to build some of that resilience and get some additional capacity in there. Recognising that good access is more than getting an appointment, so face-to-face, triage, online consultation as well, and making sure that we can provide the right person that patient needs for the right care at that time. And just to finish off, mentioning the network DES, again, which builds wider multidisciplinary teams to help meet the needs of the population and ensure that the patients do get to see those right people and the best staff placed to meet the needs of the patient. And I'll pause there.
Thank you, Jo. Can I check, Dr. Trimble, did you want to speak, or are you here to answer questions?
No, I'm here to answer questions.
Right, okay, thank you. Before I open this up to the committee, and I am not in any doubt that you're going to have a lot of questions, because this is the #1 issue for our residents in Nottinghamshire. But can I just turn you to page 27 of the data that you've given us? It says the latest access data available is for June 2021. And we've been in lockdown. And the face-to-face appointments are over 298,000. And the video is 3,000. This surely cannot be right. People are telling us they can't get face-to-face appointments. So how come you have 298,000 face-to-face appointments? If I rang the doctor today, I would not get a face-to-face appointment. I know some doctors of surgeries are extremely good, and without a shadow of a doubt, some are extremely bad. And this business of telephone calls is causing problems with people who have major surgical issues and they're being missed. So how do you account for this? And I can give you one example. I represent 23 parish councils, And one lady came out to me and she said, "Can you help me?" Her son is 47 years of age, has not been allowed to see the doctor. It's been telephone conversations right through lockdown. When he eventually was seen, he's got grade 4 prostate cancer and they can do nothing for him. And this is not the first time I've heard something along these lines. Whether or not you feel that the telephone calls are acceptable, I can assure you they're not. They don't work. People don't like them. And there is nothing to replace a face-to-face meeting with the doctor. So I would like to know how on earth these figures came about, because to imply that there's been more face-to-face meetings than telephone calls, I find absolutely amazing. I don't know whether anybody else has picked up on that. And also, people, I was told the other day of somebody who rang the doctor and was told they had 3 weeks to wait for an appointment. This is outrageous, outrageous that people are having to wait this length of time. And there's no doubt about it, things are being missed. So perhaps you can answer that in your own time, and then I will just open it up to everybody. Thank you.
So Councillor Saddington, I think there's 3 questions there, and perhaps if I could direct the question about the data accuracy to Jo. Sorry, Dr. Trimble, who I didn't fully introduce, is a qualified general practitioner of significant experience, but now works for the CCG and supports us to ensure that we have the right professional expertise in commissioning general practice, and might be able to give a view about the kind of, so the issue around telephone consultations. It's probably just worth saying that that pre-pandemic, although clearly the pandemic has exacerbated issues around availability of face-to-face appointments, there was a national direction towards more digital consultations, and so that is a kind of national policy direction, and probably, well, it isn't one that we have any discretion about locally. But clearly, the point you make, which is the one I might ask Dr. Trimble to comment upon, is how clinical judgment can be deployed to make sure that the appropriate patients then get a face-to-face consultation at the right time in order to manage their condition. So if we could take those 2 separately, if that's okay. So Jo, could you comment on the data issue?
Certainly. So the data that we've got in front of us, we get on a monthly basis, and we have around a 2.5-3 months timeline in this information being presented to us by our colleagues at NHS Digital. The information is extracted directly from the clinical systems of every one of our general practices. So each one of our general practices has the appointment types classified within their individual clinical systems, and when a person books an appointment, be that face-to-face, video or remote, it will be captured in the way of delivery, the method of delivery for that appointment. What this isn't, it is not the triage element of that. So triage happens, the first thing that you have is I today ring my GP and say I need to speak to somebody about X, and then I will go through a clinical triage, and then I may be converted into an appointment that they can deal with me face-to-face, or an appointment where they can deal with me over the phone or remotely. So this is their actual appointments. It's not that first contact speaking to the practice saying that you need to speak to somebody or to see to somebody regarding their conditions. But this is actual data that's extracted from our general practices by a third party on our behalf. So this is the live information for June in terms of the appointment numbers that have taken place. So of those appointments that were booked post-triage, 57% of those patients will have been seen face-to-face. Now, they may have had a telephone conversation with a GP or a clinician prior to that meeting, to that appointment, but that's the conversion rate of face-to-face undertaken in June. So 57% of our patients that were seen in June were actually seen for an appointment face-to-face. And the video and online does seem to be a lower number, and that is consistent right across the months. If we look back at activity even pre-pandemic, we were starting to see those video online changes based on national guidance and policy movements happening, but people seem to prefer the telephone consultation over the video. So those numbers aren't surprising, certainly to us, but they are driven by the pandemic and by national policy. Okay.
Thank you, Chairman, and thank you for coming along this morning. Just picking up actually on the data that Sue presented, I actually showed that table to a couple of GP friends of mine, and they indicated to me that their perception was that the face-to-face visits would include people having basic nursing treatment at the GP practice and not necessarily just seeing a GP. And they actually suggested that probably the vast proportion of those numbers were people going along for routine diabetes appointments, checkups, blood tests, vaccinations, just the general kind of stuff that can be done by a triage nurse as opposed to a GP face-to-face consultation. And actually, if that's true, I think that does suggest what is more in line with what Councillor Saddington is saying, which is our experience in dealing with our constituents, that almost everybody you speak to is struggling to get a face-to-face appointment. I too have a very personal and tragic story as well. So I think we've all got those as well, of where people are being missed through the net. But perhaps you'd like to comment, is that the case, and therefore is that data therefore more reasonable? The basis this is not people having face-to-face appointments with GPs, that's included, but a significant proportion of it will be just nurse visits.
Do you want to do that? So yes, you are right, Councillor Barney. It is appointments at a general practice. It is not just a GP appointment. So it's the number of appointments undertaken by our general practices with their full staffing complement. So that may be a clinical pharmacist where there's a medication review needed. It may be a first contact physio where they're the most appropriate person to see them with musculoskeletal concerns and advice needed. It may be with nurse, HCA or a GP. So it is the totality of the appointments being undertaken across general practice.
That's really helpful, thank you. And I think that is pertinent really in as to why we as a committee have chosen to do a fundamental review of primary care. It is the number one thing that our constituents tell us that they have issues with in terms of their experience with the NHS, and we're delighted to be representing them and trying to understand why. So the wider committee might not appreciate, but Councillor Saddington and I had a meeting with Lucy some weeks ago. And in terms of our scrutiny of primary care, I wrongly and naively, I'm newly elected, so I'm naive about a lot of things, assumed it would be quite simple, because in the world of KPIs, which have existed through many different colours of government over many decades, and with the assumption that I think that I had at a prejudice that the NHS has seen a gradual creep away from primary care and actual medicine towards managerial targets and daily mail tables of how GPs are run on their KPIs rather than on actually their primary care. Lucy indicated to us that readily available data for us to compare one surgery against another is very, very hard to come across. And again, I found that almost extraordinary to believe. And so I was delighted when Joe forwarded us this paper, and we've had this data to look through, and we can see that there are a number of areas where KPIs are collected. But I spent some time going through each of the links which are included in this and discovered that concur with what Lucy had said, that actually most of the data that is collected on a statutory basis by GPs is about very specific things. It's specific types of rare cancer, for example, and other areas, type 1 diabetes diagnosis rates and how quickly they get referred, rather than actually how hard is it for constituents to get to see a GP. And we know that there's a huge differentiation across the district, across Nottinghamshire, in the experience of residents in how easy it is to practice at their own local practice. And so I refer to the data on page 28, which I find actually, I mean, I'm grateful to have it, but it's so anomalised that it actually, I think, is rendered almost useless and leaves us actually with just going back to the first point. We're so happy to be looking at primary care because I think there is a disastrous situation here, and this data reveals it. We've got the alarming statistics presented that, for example, here, this is in Nottinghamshire, and this, I believe this is also, so this is 2021. You've got easy to get through to a GP practice online. You've got the best practices in Nottinghamshire achieving 98% and the worst practice achieving 30%. My gosh, that's an enormous differentiation. And you go through each of these lines and they're all very concerned. You usually get to see a GP or speak to preferred GP. 64%, okay, not too bad. 24%, absolutely terrible. But where are these practices? Who are these practices? And why as a committee can we not compare one against the other just so we can take best practice and set it against worst practice? And I suspect on the basis of Lucy's comments and the data you've provided us, which is the national picture, that this is something which is probably mirrored across the country. And I have to say, 3 months into this job, I am utterly astonished that we do not have the levers to scrutinise at a basic level across our county the differences in GP practices. Preach over, enough said, but I think that this is exactly why we're undertaking this review of primary care, and I hope that the outcome of this committee might have wider ramifications than just Nottinghamshire.
Yes, I think so. I mean, I'm clearly not surprised that this is the major issue that your constituents talk to you about when you talk about healthcare, because, as I say, everybody will be registered with a general practitioner. Not everybody has to access hospital services. And as Joe's described, our general practitioners are independent contractors, but working to a national contract, and they are funded to provide holistic care. And that's the history of general practice. It's family medicine, it's population health management, you know, all these new terms, but fundamentally it is family medicine. And unlike other parts of the health sector, they don't get paid for episodes of care. They get paid a sum of money to run their premises and employ the right staff so that they can support the changing needs of their population at any time. And some, you know, we know, don't we? We know from our own personal experience that some citizens need much more primary care support, and some of us are very lucky and we don't. And that's the way primary care is contracted and established. And I suppose the point being to ensure that to support GPs in being family medical practitioners, not managing people through individual episodes of care. And I suppose that's the background to how primary care is contracted, how primary care is provided. We do recognise, like the rest of you, that, you know, we're citizens as well as healthcare professionals, that the demands on all of our healthcare services now are greater than they ever were. They were growing pre-COVID and they're growing now. I think what we would like to do with you is to understand, and there are mechanisms of taking feedback on individual issues. We do not want to lose those individual issues, and please do not ever think that when we sit here and talk to you about high-level data that's 3 months in retrospect, that we aren't interested in individuals, in our, you know, our own families and friends. We absolutely are. So there are mechanisms for us receiving and acting upon your individual concerns, and also, you know, we do want to work with you if you have, and we work with colleagues in Healthwatch, if you have areas of particular concern, we will take those concerns and we will come back and we will go through it with you. So I think, you know, we don't contract for individual episodes of care as I've described, but we do want, and actually what we want to do is we want to support general practitioners to recover from COVID, you know, to respond to, you know, our increasingly frail and elderly population. Actually, we need to do it together, and I think that this is the kind of environment where we can do it together. And it's almost like both of us shining up, you know, turning a mirror. You know, what does the population want and need, and do we need to support our population in understanding how to best get that care? So, for example, you know, 20 years ago, if you had a bad back, you'd probably see your GP, and then you might get referred to hospital, and then you might wait 3 months, by which time, you know, your back problem had probably got worse. Now you can probably see a first contact physiotherapist in your surgery, proper preventative medicine. That's something that wasn't offered 10 years ago. So we want to help our population understand and these are national changes, they aren't changes that we are implementing locally. We want to help our population understand how and what they've got the right to ask for. You know, we have mental health workers in general practice. You know, if your concerns are physical health exacerbated by mental health, how do you get to see a mental health worker? How might you get community support? So I think what we want to hear from you is, as you are already very articulately describing the problems that people are having, and we also want to have that dialogue back with you about how we can help people access the services that are changing significantly. And I, would stress this is something that precedes the pandemic. So I think if we can do it by way of dialogue, I think we can get into those specific issues, either about individual patients or where we've got areas of more general concern.
Yeah, thank you, Chair. Yeah, thanks for the update. It obviously remains frustrating for residents, and it's the largest complaint we get about the time it takes to book an appointment. And it is a major complaint. And the appendix states that 29,906 residents had to wait more than 28 days. But in my view, that's probably too long, But that's 14% of bookings are released for June. 31% of residents had to wait over a week for an appointment. But the report also states, which I find this is one of the misconceptions about GP practices. So there's no actual contractual obligation for a time limit in your contracts. And that really is a bit of a shock, because most people expect to see a doctor sort of straight away. And that's the thing. But there's no contractual obligation by the GP to see anybody within a certain time, and I just wonder if that's something that needs looking at. Moving on to the residents, who 37% of residents no longer have face-to-face appointments, and they're relying on phone appointments, and some people just get on with that and some people don't like it at all. It's a personal thing, but they're being forced down that line. So our GP practices being forced down the route of becoming more remote because of the volume. So the other misconception is as well, so GP practices are obviously, as you know, Lucy, massively different. So I'll take two examples, like Torquard Way in Hucknall, that's got a patient base of 12,500, and then Jacksdale that's got 3. So that's massive difference between provision. And the other issue we get in there is as well, along with the local district and borough building plans, I've had a couple of cases now where residents have been told that they're no longer within their geographical area and have been removed from the practice list. Well, in actual fact, historically, they are within that parish, and you must have that where you are, Sue, because I've had people being chucked off the doctor's list because they're currently not in the geographical area of that practice, but historically they are. So that's an issue going forward that we've got to look at. So more hub style health provision is going to have to be, we're going to have to go down that route. The other thing is as well, perhaps you could answer this, sorry, I forgot your name, Dr. Trimble, because who at the GP practice is the person in charge when it comes to repeat prescriptions? Because when we get people with onset dementia and mental health and they forget, come back and get their repeat prescription, because in their perception, I've had 2 cases actually, one with blood pressure tablets and one with water tablets, who in their perception they only needed 1 course, and obviously that they're on a repeat prescription. Whose job is it to check that they're coming back for them, especially when you've got people with onset dementia and mental health issues? Whose job is it in the practice and where does that responsibility fall as primary care? Because that's a real issue, because I've had people passing out, fainting, and people swelling up and being rushed off to hospital because on a repeat prescription basis, if they've got mental health issues or onset dementia and they don't know they've got to come back for that repeat prescription. And the other side of it as well is a question I asked about 6 to 8 months ago now about blister packs. because some pharmacies were refusing to issue blister packs, and they're very important, as you know, especially during COVID, because they provide a regulatory day-to-day. I've took that one, I've took that one, I've took that one. So have we addressed that issue? Thank you, Chair.
So could I? Yeah, I think if Dr. Trimble could start, I think the sort of recurring theme about how clinicians decide how quickly patients should be seen, how you use your clinical judgment around management of patients. If you could start with that, Ian, is that okay?
Yes, if I just wanted to come back on a couple of the earlier questions as well. Hope it won't be too long. Just on the initial question about the appointment data that you referred to, Councillor Saddington. There is a problem with the data, the national data, the categorisation, as you've pointed out. And in fact, for information, there is a national programme. We love our acronyms. It's called GPAD, so GP Access Data. So the whole system is currently under review, and the appointment categories are under review. And that will be put in place. It's actually going to be put in place by October. So just to point out that categorisation is currently under review. Your second point around triage, face-to-face is obviously the gold standard. No GP would disagree with you. The reason for the move to total triage, as it was called, which means everybody having to have a phone call before they could get through the doors, was a national direction at the onset of COVID. So that's why practices have had this system in place over the past year, and it's what's led to what I would call a crisis of perception. So patients perceive that the doctor's doors are closed, they're not available, the waiting rooms are empty, the doctors are doing nothing. The doctors are feeling that demand is higher than ever, they're busier than ever, and they're struggling to keep up. And that is what has led to that crisis. As we recover from COVID, we're moving into a period of recovery, and practices are still triaging, but they are now opening up direct and offering more face-to-face appointments, and hope to do so more in the future. I don't think any would disagree with you. On your point about the patient survey data, we gave you aggregate and top and bottom figures. If you explore that website a little bit further, you can actually download all the figures for all the practices in Nottinghamshire, indeed the whole country, and compare them for yourselves. So that those figures are, you can download a 32 meg spreadsheet, which will give you that data for every practice in the country, and you can compare all of them openly. Unfortunately, they're only published once a year, so that's it's not very flexible data, but it is publicly available. In terms of waiting times, your point about about not having waiting times stipulated in the contract, you're absolutely correct. It isn't in there at the present time. There has just been a revision to the contract for 22-23, when there will actually be, as part of an incentive scheme under one of the subsidiary contracts, there will actually be an indicator around the percentage of patients who are able to book an appointment within a specified time. So that is being addressed at a national level. You may not like it. The indicator is the number of appointments available within 2 weeks. I think a lot of people would argue that that's still too long. And Lucy makes the point that actually it's up to the clinicians themselves to determine whether actually patients need to be seen that day. And half, as Jo pointed out in her presentation, more than half of patients who request appointment need to be seen the same day and are seen the same day. Finally, and I'll stop then, you asked about prescriptions and who is responsible for monitoring repeat prescriptions. It is the GP contractor. It's the responsibility of the GP contractor to have a system in place to review and monitor repeat prescriptions. So I hope that's a direct answer to that question.
Yeah.
It was just to answer the blister pack question, because obviously blister packs are part of the contract for community pharmacy, so actually it's an NHS England commissioned service, not our own, but we can certainly take it away and link with colleagues there. If you have any specifics, we can point you in the direction of the team at NHS England that would be able to support you with that.
Yeah, sorry. Yeah, on that particular point, blister packs, because obviously after the start package is finished and they're being looked after by care, which falls under the county council, from direct independent payments or fully managed packages, those patients then fall back under the doctor's primary care and the carers that are coming in, because the carers that are coming in aren't really always qualified to monitor that situation. So that's why it's important that the administration of the blister packs is of paramount importance, because the doctors are relying on that service to keep that patient out of the practice. So that's where there was a bit of a fluctuation on it, and I think I'm glad you said that it's the doctor's response, the GP practice's responsibility, because it's particularly acute with dementia and mental health, and that's the problem. There doesn't seem to be any backup to that. So if the doctor misses it and the patient doesn't come in, they fall out of the system. Then they end up back in hospital. If you know what I'm saying.
Yes, I mean, I think, excuse me, but I mean, you can answer this better than me in practice, but medications that are on prescription are regularly reviewed. So that it isn't just a case of them being requested, they are regularly reviewed. But obviously, if you've got cases where you think that's not happening, that is the sort of thing we would want to know about. So it shouldn't be left to chance that somebody with a cognitive impairment remembers that their prescription is overdue, is my point.
But then, of course, there was the third and final question, which didn't get answered, about parish boundaries and GP practices chucking residents out because of new builds within closer proximity to the existing.
Yeah, I think, yes, there was two questions. We haven't talked about kind of digital exclusion and people that can and can't use technology. And just to say and again, I'm not trying to defer things. There are so many things that we could talk to you about, but we would happily talk to you about how you can't just assume that digital works for everybody, and how we're looking at health inequalities and the differential impacts. So I think it's just say that point is recognised. Practice boundaries, you're absolutely right. So the way that GPs get paid is they have a list size, they get a sum of money, as Joe described, for every patient on that list. So they will look at the money that they're getting and the number of patients registering, and they will say, well, actually, we've now got 50 more patients on our list. So that is a constant sort of, everybody's entitled to be registered with a general practice according to where they live and their practice boundary. And again, we will always work with people who feel that they are not able, well, everybody has a right to be registered. But boundaries will change, unfortunately, when you have, areas like Newark where there's a growth point. Boundaries will necessarily change.
Thank you. It's really difficult. I have to say, I have a brilliant GP and I love telephone appointments. But I know I live in an area where I'm really lucky, and I'm looking at the data. I hadn't gone down to the website. And I can see immediately a stone's throw from where my GP's surgery is across the river outside the county in the city. The data is much worse. And I think the issue of, you talked about individual cases, doing all this on anecdotal evidence really of bad stories and bad situations is not the way to go. We need to look at the data to deal with it properly and holistically. And so I think really, this data exists on this database, but I'm sitting here putting in surgeries I know, and that's obviously not the way to do it. I think we need to see the data broken down by region, by area, because we know the areas where the GPs are going to be having the most pressure on them because the patients have got the most illness often because of their socioeconomic situation. And we also need to see it, I think, by the contractual nature of the GP service, because you're talking a lot about how they're paid. And, I don't know and I don't understand how the way the GPs are paid impacts on how they then, what services they provide. Because presumably, depending on the contractual arrangements that they're under, there may be benefits to somebody somewhere in the system for not providing more nurses, more doctors, more physiotherapists. So I quite like to see it by the contractual arrangements, the payment arrangements, who owns the GP surgery, and by the local area, and frankly by the GP. But I can see that that is available here, but that's too hard to take in given the number of GP surgeries that exist. Thank you.
So Councillor Gannon, forgive me, I wasn't suggesting that we deal with anecdote and individual patients. I just wanted to make colleagues aware that if you have particular issues in your mailbag from individual constituents, we will deal with them. I don't want you to think that was going to get lost. You are absolutely right. There are a number of different factors that impact upon people's experience of general practice, and that can be we know that in the city and also parts of the county, you have very different population health needs, and those different population health needs need a different type of service. We know that we have different recruitment workforce issues in different parts of the county, and we also know that the estate, and we've seen that certainly through COVID, impacts on the way that care can be provided. So I think those are the matter. I mean, we can talk to you about different contractual arrangements, but actually they are quite straightforward and they're pretty similar. It doesn't really make much difference. You paid a sum of money for the patients per patient on the list, and then you can opt in, which most practices do, not all, but most practices opt in to provide the enhanced services. But I think your point that we could look at potentially, because primary care networks are about achieving exactly what you've described and what Councillor Martin mentioned. So you might have an area in the county where there's a practice of 3,000 patients, a practice of 12,000, and a practice of 5,000. One might be operating out of purpose-built premises, one might be operating out of a converted building. That what the whole PCN approach is about, helping those work together to provide the best level of care that they can as a group of practices. So I actually absolutely think we could start to look at kind of PCN type data, and I think that would be the right level of granularity to be sensitive to the individual population health needs as well. So we can do, and we need to be, we can share with you, we will be totally transparent. We know where GPs are saying, if we could invest in our estate, if we could build some extra clinic rooms, we could provide additional care. If we could spend some money in our premises, we could segregate patients and provide services in a different way. We can provide all that information to you so that you can be cited on how we're making our decisions.
Hello, Dr. Trimble, you were my family's doctor for many years, and only the other day my dad was saying what a fantastic GP you were, so hi. I'm going to go from slightly a different angle, I suppose, in a lot of ways, because as the meeting has gone on, a lot of people have already said what I was going to say, in particular with regards to the national directive for face-to-face appointments, and the fact that GP surgeries were then faced with deciding what exactly that criteria should be amidst the pandemic. And actually that was incredibly challenging, I do believe, from friends that I've spoken to are actually GPs. So that's my first thing. The other thing is with regards to the fact that during the pandemic, I feel that GPs have actually fulfilled the role of other health practitioners that actually were taken out of the system to work elsewhere. So, for example, I know we're not talking about, but I work with a group of lockdown mums, and actually GPs have fulfilled a role of a health visitor throughout the lockdown, that mums with babies have had more contact with GPs, and actually they have done with health visitors throughout the pandemic. And I can say that from a personal experience as well. The one thing that is brought up with me is with regards to the triage system, with regards to the point where you even get to talk to a doctor, and that is that sometimes people are feeling that, and again, this isn't any criticism as such, it's just feedback really, is that they're not getting past the receptionist, and that is proving to be a real challenge at times. And again, I know that from a personal perspective, where I've had to then pick up the phone to get someone who's actually quite seriously ill an appointment. And if they didn't have me, I don't know what situation they would be in now. So that is a challenge. And I think that's larger than me just being anecdotal about that. I think it's quite a big issue that they're not even going to be able to get past that first hurdle. I do think personally that that goes back to the fact that there was a national directive with very little guidance as to who should actually be getting an appointment and who hadn't. And it is very, very difficult to make those judgments. A lot of what has already been said, I do agree with. I also wanted to bring up about the data by doctors' surgeries. I think one thing we do have to acknowledge in Nottinghamshire that we have very clear health inequalities in Nottinghamshire, and the pressure on certain GP surgeries is very different to other GP surgeries. So I do think we have to put it into context in that situation as well, that what one GP surgery is facing is very different to another GP. It's a bit like the country mouse and the town mouse in a lot of ways. It is very, very different. So I think any analysis that is done by GP surgeries has to be put into context as well. I don't think it's good enough for us to say, you're not doing enough face-to-face because of this, and you're not doing enough face-to-face, or you're doing lots and lots. I think the context around it is really, really essential, as is the funding, what is going into primary care as well. I think that needs addressing. I know the BMA have recently launched a petition which calls for boosts for GP funding and their premises. Their premises aren't actually fit for purpose. So when we're talking about face-to-face and we're talking about protecting people post-pandemic, GP surgeries often, the actual, doctors actually surgery isn't often conducive actually to that face-to-face. So where they can do those face-to-face appointments are actually limited anyway. So I think there's lots of challenges for GP surgeries that are out there. So yes, I do think there's an issue with regards to triaging. I think there are certainly certain people that would rather a face-to-face appointment. There are certain people that would rather a telephone appointment. My own experience with my own doctor's surgery, as when I was talking to the women prior to this meeting, has actually been really positive with regards to paediatrics. So often if you say that you've got a child that is under the age of so-and-so, the doctor will see that child. And as a child who's started mixing with children over the last 6 months and has got everything absolutely going, we've actually seen the GP quite a few times. And last but certainly not least is, I do think that GPs have played a critical role during the pandemic. I've people that have done their GP practice during the day, they've been vaccinating on their days off. So they've actually played a critical role throughout this pandemic. And I think we should actually acknowledge that as well, often putting them on the line when they have seen patients face to face at a time when the pandemic was really difficult. And last and certainly not least, I did want to voice actually my concerns about the workload and pressure that is currently on GPs at the moment. One of my worries is that people are walking away from either choosing to become a GP or are so burnt out from the pandemic, and then have suddenly got an influx of people that are suddenly, that need that's been hurting for the past 12 months that we've kind of ignored during the pandemic is suddenly a GP appointment. And 10-minute appointments that often GPs are having to face. And the other thing about dealing with only one issue at a time, that's quite difficult as well for local residents to come to terms with and understand as well. So if we can do something around that, the fact is that they go phone up and they say, oh, well, while I'm here, I've actually got this problem, and they're being told, actually, we can only deal with your knee, or we can only deal with the eye situation at a time as well. So within all of that, with regards to that I do think it is a challenge for people to get those face-to-face appointments. In the midst of all of that, I do think it's important that we have some context. And I do think it's important that people do speak up on behalf of GPs and the role that they have played during the pandemic. And the fact is that the buildings aren't necessarily post-pandemic proof, and we could do with some funding from that nationally, and that GPs do need our support, as well as criticising the lack of face-to-face appointments. It's mine. Thank you.
Thank you. That's a very balanced and extremely fair, and I think that is the world that we witness. Actually, it's really good well, it's helpful that we've got the same perception, because I think we're starting from the same perspective. I think your point about differential health inequalities is absolutely correct. Last time I checked, the average healthy life expectancy across the county, there is a difference of 10 years. So that's people being on 2 or more medications. That's something that we can know, but we mustn't just accept. But we also, I have to say, we mustn't assume that we're in those areas where there are greater health inequalities, there are manifestly greater health needs, that there isn't good primary care, because some of the best primary care, I won't name any more than I'm going to name and shame people where we might have concerns. There's some fantastic primary care out there in some of our, I could name GPs who I have sat in and watched the way that they care for patients, the most complex patients. And a lot of it isn't medicine, actually. It's about understanding them, their families, what the community support they need. So I think your point is absolutely right. So to that, when we recognise the differential health inequalities and we recognise the different pressures for general practice that causes, one of the things that we would like to do going forward, and conversations like this quite help us actually, is to make sure that we invest. If we need to differentially invest, we differentially invest. Now, the problem with that is that if you don't get more money, that means disinvesting from somewhere to invest somewhere else. We don't believe there's anywhere we can disinvest from, and we are receiving net additional funding into general practice. But I think working with colleagues like yourselves, it's just to get a real view on how we should focus our investment, and how we can do that to support general practice. And I think your comments about, I mean, again, we're patients as well as healthcare workers. Around the pressure, I mean, receptionists, I mean, and we understand what you say. We have heard it said before, but you also have to bear in mind, we have to bear in mind that receptionists are the gatekeepers at the moment, aren't they? They have a very, very sort of complex system, and when we have national issues like the blood bottles, they're the people who are receiving those sorts of questions. So I think if we recognise that everybody, it is fundamental right to good primary care. It's your gateway to all the rest of your healthcare needs. But if we can do it in a supportive way, but also target where we need to improve, that is what we've got to do. So thank you.
Yeah, I just wanted a point of clarity. When I spoke about health inequalities, I didn't mean for HIP that surgery is when worse. What I did mean was, if we put it into context, we can actually see that doctor's surgery, despite all those pressures, is doing those amount of face-to-face, and those that are facing those, I think context around what's going on in an area, I think, is really important when you're analysing the effectiveness of any health service. And so what I was saying is there are Nottinghamshire is very different county, and we need to take that into account, is what I was saying.
And that's what I took.
Okay.
Thank you, Chairman. Yeah, hello. Thanks again for today. Just a few things. I want to drill down a little bit more on the data that Councillor Barney raised, and also your mention around this GPAD system. Where does GPAD access from? How does that output? If the stats from that output are problematic, for example, who would review that data, and what actions and through which body would those actions be taken? Because it occurs to me that one of the things that you're talking around funding as well, if we can understand that data and recognise within that data where those challenges are, obviously that investment can be targeted for the right places. Again, who would review that, and where would that decision be made around that change in investment to that area? So effectively getting the money to the people that need it. And finally, if we talk about quality monitoring, so this is completely separate. Somebody I know was undiagnosed with an illness at a GP for a year. It took the transfer to a different GP for that illness to be recognised, and I must say it was on the first appointment with that GP that was recognised. I accept, obviously, people have different experience levels of different things, and people see different things and would recognise it better. I just wonder, the information sharing across GP practices on recognising different illnesses. How does that come about? And again, what forum is that done in, and how is that reported back? Thank you.
Probably best I'll answer the differential investment if you want to answer the other questions. Okay.
If I could respond to general practice access data or GPAD, it's a system of categorization which categorizes appointments either as urgent, non-urgent, face-to-face, and the type of practitioner that is being seen. So there are a number of categories. They're standardized. And what has happened in the programme to date is each of the practices has been required in their appointment systems to standardise all of the appointments that they have on their practice systems to these national standards. The data is then extracted on a monthly basis directly from the GP system. That is then aggregated by NHS Digital. So it's NHS Digital, which is the national body that actually extracts and holds that data. In terms of scrutiny of that data, at the moment, that is only scrutinised at a national level. The data that we have shared with you it's available to the public, but it's only aggregated at a CCG level. So we're unable as yet to see that at a practice level. But I stress as yet, I suspect that'll change. In terms of your other question around, it's part quality, it's part about variation. And it goes back to the earlier comments around triage. And triage was introduced to reduce the risk of infection. So that was the driver. So on the one hand, you've driven down the risk of people catching COVID in surgery, but on the other hand, you've increased the risk of misdiagnosis. And I suspect that this will be revisited and reviewed. And increasingly, what will happen post-COVID is that we will see that phone and online consultations will be offered as an option rather than mandated as present. And I think that'll be better all round. But the challenge, which you've correctly identified, is how to make everywhere as good as the best. And practices do vary enormously, not just in terms of access, but in terms of clinical acumen, as you point out. You asked how that is, how clinical quality and clinical practice is shared. That's shared in each part of the county, in the 3 parts of Nottinghamshire, through a programme of postgraduate education where practices come together and a range of topics are discussed at protected learning time events. So there is a systematic process of postgraduate education, and not just for the GPs, but for the nurses and the practice staff as well.
And just to add to that, and as Ian says, unfortunately, there will always be some variation, but we have across the county effectively referral templates, which everybody accesses, so every GP accesses it, and it sort of takes you down an algorithm that responds to individual symptoms. I don't know off the top of my head how many pathways are on ARVNs and F12 in, but there are many, 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 aren't they? So there is as much standardisation as you can possibly have around, you present with a certain set of symptoms around how you may assess them and either refer them on or treat them. But as Ian then says, we have these monthly protected learning times where we might release a new pathway, and then people are educated on how to use it. So it's not, there is quite a lot of systemisation in behind the scenes.
Can I come back? Sorry. Yes, thank you. Just thank you very much for that, by the way. Thank you, because it's trying to understand how that all comes together that I think answers those sort of moments where people go through this long process of diagnosis and then they have that sudden relief of, oh, we found out, but why didn't, what was missed there, or what was, and I also accept, I think, and I'm sure people would, that sometimes symptoms develop over time, and so it's difficult to know, maybe in the early stages, what what will come out at the end. But I think, yeah, that sharing of best practice is really important. You mentioned post-COVID as a marker almost. Will we ever be post-COVID? I suppose is the question I would ask. And so, what maybe within the terms of being post-COVID, are we saying, you know, at the point where the national advice, if you like, becomes business as usual? Is that what we're saying? Is that what post-COVID is, in your opinion? Because, you know, I believe, you know, being medical myself, though, of course, but I believe that post-COVID would mean that it would disappear.
Yes, I mean, every winter we have a season, don't we, where we have infectious diseases, we have flu, we have RSV, we have a number of, and we have methods of treating, immunising people, of treating them. But you are right, we hope to get to a point. But what we know is, I think by post-COVID, we know that COVID has created a massive backlog for both planned care and emergency care. We are working harder than you could imagine. In Nottingham, particularly in Nottinghamshire, particularly to address the elective backlog, to get that back to the point where we were pre-COVID. But we hope that, one can't see these things, can we? That COVID will be managed in the way that other seasonal infectious diseases are managed. But no, we know these things. I mean, we've got. I mean, not to digress, but we have issues around, children's mental health, adult mental, a number of issues that we're going to be dealing with for years to come, no doubt.
Oh, thank you, Madam Chairman. Well, as councillors, we never know what we're going to be asked next, do we, when the phone rings or the emails come through. But it has to be said that over the last few months in particular, more and more calls and messages are coming in about health-related matters, and not necessarily COVID, but pre-COVID as well. And I know there's an awful lot of pressure on the whole system. We all know that. And on the GP side of things, I suspect that there's still problems with people attending or wanting to make appointments with GPs who really shouldn't be troubling the GPs with whatever it is they're phoning about. And to a certain extent, I understand why we have this triage system with the receptionist now filtering. But it has to be said that a lot of residents, a lot of patients are hesitant and are worried about sharing personal details with the receptionist. And I don't know how you manage that. I don't come here with any magic answers. That's why we look to experts like yourselves. But I wanted to come along today because I received an email, it was over the bank holiday weekend, which is, I suspect, typical of messages that councillors across the board are receiving. And I happened to mention it to the chairman, and she said, "Oh, come along and share it." And I have shared it with Lucy, and I must thank Lucy and colleagues for your responses. But it's typical of the questions we're getting. And of course, we as members, probably like your good selves, feel very frustrated and feel the real need to actually get something done. And one of the challenges we have is knowing who to speak to within this massive organisation, which is our NHS. And so it's a good reason for having this committee, of course. But I'm not going to name names or name practices, but the comments I received in this email, which I've shared, refers to obviously difficulties contacting or getting an appointment with the local GP, and also it does refer to a city council issue as well. And I know you're not really talking about hospitals as much today, but it says, "I've been waiting over 2 years for a knee replacement. Contacted a city hospital this week, was told to be another 6 months due to a shortage of beds. I despair. If you phone the local surgery, you can't see a doctor face to face. And if you're lucky, you're just told to take some more painkillers. I currently take 12 painkillers every day, and gradually the distance I can walk has decreased. And at this rate, I'll be in a wheelchair or dead before my knees are replaced. I also need a hernia and was told it will be 2022 at least before it's addressed." But as I say, we all know the pressures are there, and as I say, there is no magic answer, magic solution. But somehow we need to raise the awareness, if it needs to be raised anymore, of the frustrations and despair that is being faced by people. And this gentleman says, my health is slowly getting worse, and why do I have to sit on the phone for at least half an hour before anyone answers the phone at the city hospital? I'm really sorry to bother you. That's another thing that gets you. People are apologising for troubling me or us across the board, and I'm sure stereotypical doctors, oh, I'm sorry to trouble you, doctor, I've got a problem. We've all seen that over the years, but there is a real feeling and a growing feeling out there of I hate to use the word despair. That's probably a bit of an exaggeration, or not the right word to use, but I'm just simply reading it from this real email that came through to me. And people are looking for answers. And again, a lot of points have been raised today, and you are giving some answers to those. But please, can you shed some light why most people are feeling abandoned by their doctors and the NHS? And that, sadly, is the perception and feeling out there. Now, I know, speaking to you and colleagues, that the last thing you wanted to do is abandon people, and it is a difficult situation we find ourselves in. But I mean, we know that more and more resources are coming in, and we've heard this morning that it's difficult to actually get the people to, even if budgets are there, and it is difficult. I know it's difficult, but between us, we are responsible. We have to raise these comments and concerns that are raised by the public, and here we are doing so. But we watch with interest, and because at the end of the day, we all have an interest and a need in this, but particularly those of us who are the voice of residents and patients, we are getting, as I say, more and more such cases coming in, and I know you're taking it very seriously on your committee. So thank you for letting me raise this, and also I must thank Lucy and colleagues for giving me a response I've had directly to this particular case. Thank you.
I don't think on that particular issue, no, if that's okay. Thank you.
Thank you. What we're hearing is there's a lot of disquiet and concern about GP services, and obviously this has been exacerbated by the pandemic. But I wonder if, not right now maybe, but if you could provide us with the data on the amount per patient you're getting over the years, and the number of appointments being made with the GP and with other services within the GP's practice per year, so we can understand to what extent these problems are being driven by, maybe in some cases, suboptimal GPs, and maybe by increased pressures, because we need to understand whether you have the resources to deliver the services that we want. Thank you.
Yes, I think we can do that, and I think both of your challenges about how we could present data to you in a way that enables us to look at it to solve the problem, I think are really helpful. So if you could leave that with us, and I can talk to Martin actually about how we can get that back to you, but I think that's a very fair point.
Lucy, I'm coming back to that in a few minutes, but I think I'm correct that Councillor Wilmot wants to speak. Yes.
Thank you very much, Chair. Can I say, first of all, I'm very, very disappointed that a Health Watch representative is not here. This is the second meeting that they've not been present. And their job, as we all know, is the eyes and ears of the residents, carers and patients. And it's essential that their views are aired. And, you know, I do feel that they should be here, especially for this very, very important meeting. Oh, anyway, thank you very much, all of you, for this report. It's very enlightening, just to say the least. What it doesn't make clear is the health inequalities that exist at the present time in the county and what the plan is to deal with them. I speak explicitly about the healthcare crisis in Hucknall, where residents tell me it is difficult, almost impossible to get a doctor's appointment. I regularly attend my local doctors for obvious reasons, and I must say that our staff and GPs are absolutely marvellous. We do, however, have a healthcare crisis in Hucknall, We have a town now of 42,000 residents. Now, when I first moved into Hucknall, I was 3 or 4 days old. There was 15,000 people. So that is the reason I'm really bringing this up as a serious issue. As I say, we now have a town of 42,000 residents, which is growing by the week. And we've only got 2 major GP surgeries, those being the Torquard and Wyburn medical practices. Residents tell me getting access to a face-to-face appointment are difficult to obtain. I'll put it that way. I don't want to be more explicit. Improving access to GP provision in Hucknall is a huge priority for Ashfield District Council. Can the CCG update us on discussions for a Cavill centre in the heart of Hucknall with timescales, funding, etc., and explain to members what a Cavill centre is? I'm sure 1 or 2 of you would like to be enlightened with that situation. Ashfield District Council have already committed close to £1 million for this project, mainly from Section 106 agreements. So will the CCG commit to holding an urgent meeting with the Hucknall County councillors to discuss the specifics of plans to improve the access to doctors in Hucknall? I also, looking at the enhanced services, I'm a little bit puzzled. Does that mean the doctors have the opportunity to get these enhanced services, and those that don't want to have the enhanced services, no need to? And so we've got a 2-part doctors' surgeries, so some giving better services than others. That's a question that needs to be answered. I'd be upset if I knew that the services that I was receiving were less than some of the others that in the area. And I was also looking at the bookings appointments, and I was to say that so many people, 26,000 more than that, to wait 28 days. I mean, you could be dead by then, couldn't you? It's an awful thing for me to have said, but you know, more than 28 days is a tremendous amount of time. You know, and people's condition can change dramatically inside those hours. It's very, very serious, I think it is anyway. And as I say, otherwise, I can tell you that people are genuinely impressed with the National Health Service, because they know how difficult it is at the present time under the present circumstances with the COVID and with everything else as well. But we do have to scrutinise from this committee as well as we possibly can, and those are the questions I am asking today.
Right.
Thank you, Chair.
Thank you, Councillor Wilmot. Can I ask that Lucy answers your questions, perhaps directly to you, because they're more parochial, but perhaps she might just like to answer your concern with regard to the 28-day wait for an appointment.
Joe on that one,
Perhaps
because I
can't.
won't have that specific data.
We won't have the breakdown of that. Forgetting to press my button, that doesn't help, does it? So we won't have the breakdown of that data, but we do know included in some of that is pre-bookable appointments that need to be booked in advance. So there will be an element of that. And there will also be an element of where individual patients want to see specific general practitioners or clinicians. So being able to book the same clinician on a regular basis may create some of those delays in those appointments, and that may be through patient choice and preference.
Okay, Dr. Trimble.
I just wanted to respond on the point about enhanced services. You raised the concern that some practices may not provide these services and therefore patients will be disadvantaged. Just to reassure you that for each of those enhanced services, when they are put out to offer, we do an equality impact assessment for precisely that reason, to assess what impact offering that service will have, and where those services are not taken up, to ensure that they are offered by an alternative contractor, to ensure that we get uniformity of provision.
If I may, Chair, it is essential that if a patient has got a certain problem and it's not the surgery hasn't taken that opportunity to have that service provided, it is a serious situation. You know, and I just want to make that abundantly clear that missing any patient out in any shape or form is not acceptable. Thank you.
Thank you very much. Councillor Martin wants another quick word.
Chair, yeah, I know you're saying it's parochial about Hucknall, but it would be enlightening for the committee to hear the CCG's strategy for moving forward with the primary care provision, as Hucknall's currently had 4,000 houses built in it recently, another 1,000 to go, and I'm sure Newark and I'm sure other areas across the county are about to experience that. So it'd be interesting to hear the strategy.
I think, Councillor Martin, it may be an answer for another meeting when Lucy, yes, I'm right, when Lucy can get her figures together, because you are referring to other areas and she won't have them at her fingertips today, which actually brings me, does anybody else want to add anything to this meeting? Right, Vice Chairman, you do.
Very quickly, because we have gone on, but I think it's been very worthwhile, and I think I for one feel very appreciative that we're at the beginning of this journey, and I'm really looking forward to continuing with it. I also want to echo the comments in positive regard to the NHS. I know that I've got a number of family members who are doctors and nurses. I know the chair has, and we've seen how hard they've worked at a personal level through this crisis, and this whole committee commends the NHS. We're all glad that we're participants of that. I also noted the comments about the rogue gatekeepers at doctors' surgeries from Councillor Welsh, and smiled, which perhaps I shouldn't. I've recently had a run-in of my own, and I think that lots of our constituents, I think this is something you will hear time and again, of just how difficult it is to access through that gatekeeper, and we all understand why, but that's a key issue, and of course it can result in great tragedy as well. But for me, really the key element to come out of this meeting, as Councillor Golan mentioned, is the data, and as Mike Adams picked up on as well, and appreciate the extra information you've given us on the national collection system, and we all look with great interest at that coming forward. But just a simple question to take away, and again, this is influenced by my own conversation with friends who are and relatives who are medics. We are seeing a discrepancy in the opening up of GP surgeries, and it's been suggested to me that there is reticence in some surgeries to open up. And some of my constituents have indicated, and with quite a high degree of anger, how come schools have gone back? How come teachers are back? How come all other services and all other areas are opening up, but doctors aren't? How come I can go to have an appointment face-to-face at the QMC and at other hospitals, but I can't see my GP? And I just wonder, is there a mechanism through the data, and I suspect there isn't, of us going forward, analysing and comparing which doctors are opening up and at what rates and which aren't? Thank you.
Lucy?
So I think we can get you that information. You are right, there is variation, and I think I just want the committee to, I'm not saying the data isn't useful. The data is incredibly useful, and we use the data where we can. But it's the whole picture. We describe it as a heat map. It's what's the data telling us about the pure stats, the KPIs. What do we know about the population? What other things do we know about the estates? I keep coming back to the estate because it may be easier for some people to see patients face to face because their estate allows them. And what's it telling us about the workforce? So you may have single-handed GPs who have got health vulnerabilities of their own. So I think your answer is yes. I think when we bring that sort of information, and when we look at that sort of information, it's something, I mean, our primary, just for colleagues' awareness, by the way, our primary care commissioning committee is held in public, and that is a national requirement, and we have as much of this debate as we possibly can in public. And if you were to go back or to listen to any of these discussions, this is exactly the sort of thing we talk about. So I think it's, the real richness is in looking at the data, but bringing all those other factors into it as well. So short answer, yes, and I think your colleague has sort of highlighted how we do that. So just looking at appointment times won't get us what we want. We need to get that sort of heat map type approach, which I think will help with the answers. So yes.
Right, I think we'll draw a line to this, and I must thank Lucy and Joe and Dr. Trimble for coming today. And as the Vice Chairman has just alluded to, this is an extremely interesting project that we've entered upon, and we don't intend that it's going to finish today. We intend to take this through many months ahead, and I'm sure that we're going to have a huge amount of questions. But just before we do finish, I think what we've learnt today is that the general public out there feel that not being able to see their GP face to face is possibly meaning that they're having delay in referrals to hospital, which is a worry in itself. If you've got a problem, you feel you want to see or speak to somebody rather than somebody on a telephone who can't see you. And I think that is really important. And one thing that hasn't been mentioned, or it was mentioned slightly by the Vice Chairman just now, I was going to be a little bit stronger about it. When I speak to the residents who complain, I say, but why don't you report your practice? And sometimes they don't know who to report to. But the main thing is they say, but we have to get past the receptionist to get an appointment. And if we complain, they're like Rottweilers, and they'll cross us off their list and we won't have a GP. And I'm afraid my message is the whole attitude of receptionists, without probably a shadow of a doubt, needs to be looked at. They're rude, they're short, they're curt, and people don't like it. And so they won't complain because they're frightened of retaliation from the so-called Rottweilers that they refer to. But moving on, Lucy, I would like you to return with a league table from citing the best of practices to the worst of practices, breaking down this chart we've got here, best and worst practice, because although it tells us, as the Vice Chairman alluded to, it doesn't tell us where they are. And we have people saying to us, my practice is dreadful. We have no proof of what they're saying. Now, if we have a problem with a school, we ask for a list per district and we get it. So what I'm asking is that you return in November to our meeting in November, please, and that we have a breakdown within each district. The number of patients at that surgery, because Councillor Martins referred to a great variation, the number of GPs within that surgery, the number of nurses within that surgery, and the number of others, so that we can have a look how there is a difference. Because I spoke to one GP who said they don't employ a lot of side people. She employs a lot of doctors, because at the end of the day, people want to see a doctor. They certainly don't want to be speaking to a receptionist who decides very much on their own medical needs when they've explained their medical needs. They don't like doing that. They don't like telling a receptionist the full details of their illness. They like to hear that they can see a doctor at 2:10 and go and put the points to the doctor. So I think we're going to find during the project that this is one of the things, that there's too many superfluous people flying about that are not doing a lot, and they want medical staff there because they've got an illness and they want to be reassured. So if we could have that breakdown, Lucy, in the same way as we get it with schools, then we can look at it. And when all these members keep saying that people are complaining, they can look when they get back home and think, well, that surgery has got a good ratio. It must just be a one-off. Because we do need to bottom this, because as everybody said, it's the biggest problem that we have. And we need to drill down and we need to get those answers. And the other thing is, can you come in November and give us as full an account as you can of the elective surgery that is on a waiting list for the future, sort of how many knees, how many hips, how many eye surgeries, so that we can see. And if you can come back with any details of how you are going to approach getting this list down. Because as Richard has referred to, this poor old man may be dead before he gets his hip. So how do you feel about that?
As I said, we will be absolutely transparent, and obviously, hopefully, we're all doing this to help support practices and, you know, manage up variation. The only thing I would just say, we have to work within our national policy context, and in terms of other professionals that support the GPs that we have to operate at the top of their licence. So things like first contact practitioners, paramedics, clinical pharmacists, CPNs, practices are funded per PCN to provide those in relation to their population numbers. So there is a requirement. So I think you may find that a small practice of 3,000 is in a PCM with a practice of 10,000 and 15,000, and the one with 3,000 doesn't have a psychiatric support, but patients from that practice might go to another one in the next. So I think when we look at those, I think it's probably, we can't say that general practice shouldn't use these support professions, because that is very much the policy direction, and we would just need to be aware of how that funding is directed and how those services are provided. But we can identify that for
Yes,
you.
I think what we need is a definite breakdown of where we go from here. And if you would come back to us in November, and in the meantime, thank you very much to you all.
So if I could just add on the elective surgery, I can talk to Martin out of the meeting, but that clearly we represent the population and we work with the hospitals to commission the best services. The management of the elective waiting list sits very much with the two acute hospitals, so we might want to think, if we're wanting to drill down to kind of specialties, those waiting lists are the hospital's waiting list. We might need to bring colleagues from the acute hospital with us.
No, that's fine. That's fine.
Thank you.
Thank you very, very much.
Thank you.
I hope we haven't given you too difficult a time.
Fine. That's very helpful. Thank you indeed.
Members, while our three guests are just clearing away, and I'm sure they'll be interested to know, the October meeting, we start yet more big projects, and we're going to have to keep to a very strict timeline, because at 2 o'clock other meetings come in here. So we do need to keep to strict timelines. But the next meeting, we will have Crisis Mental Health Services speaking to us, NUH Maternity Improvement, they'll be returning, and the Commissioner Maternity Improvement will also feature on the agenda. So we have a very, and the Bassett Law people are coming back with, guess what, their travel plan. So it is a busy meeting. We'll start 10:30 prompt. Thank you, everybody. And we will have to keep to Martin's very strict timetable, I think, on that one. Thank you to you all. Have you found it useful this morning? And hopefully you'll go away and come back with questions. Councillor Wilmot, I thought if we bring this strategy thing back, then they can go right across the board. Rather than as, yeah. Well, that should come with the planning application, shouldn't it? That they build a doctor's surgery to accommodate all these people coming in. And this is where district do not watch what's happening and do not think, or people don't ask for a surgery to be put in or a medical centre.
They're all commerce businesses in their own right.
And obviously we're going to have a lot of building and we're going to have a lot of problems, but any of us who are dual hatted, it's up to us to try and encourage GP surgeries to come in with some of the money that the builders have to pay to build there. Okay, everybody, thank you very much. Michelle. Right, well, that is something we need to ask about. And also, we do ask to ask why we're not having face-to-face in opticians. I had a new pair of glasses and we went away for a few days and I nursed the dog and he jumped back on me. He's only little, but he jumped back on me and the glasses all went askew. So I went to get another pair, which I was entitled to because it was buy one, get one half price or something. And I ordered another one. And it's worse than, I'm sure, going into a prison. They lock the doors, they let you in, you go in, they lock you in. You have to have an appointment before they let you in. And you're wearing masks all the time in there, which is great when you're trying to try glasses on because you just look like a terrorist standing there. But the whole point is that it's time they opened up. And I said to her on Saturday, why aren't you opening up? And she said, it's government policy. We're not allowed to do yet. I've never heard such tosh in all my life. But we just need to bottom this and see. Did you want to say something? Yes, please, please. Yes, don't worry, no problem. Stuart, I think we need the YouTube stopping.